So case number 1, and I didn't give you guys any histories. How cruel and awful. But, you know, in soft tissue, a lot of times it's soft tissue mass, thigh, right? There are some differences, and the history and the age can guide you a lot. There's some things that never occur in kids, or never occur in old people, or never occur in the skin, or never occur in the retroperitoneum, and that can help a lot in soft tissue pathology. But a lot of things too are patterns, and learning the patterns is the tricky part of soft tissue because there are a lot of tumors, a lot of entities. They all have weird overlapping sounding names. So I threw you guys a little bit of a softball at first. Now, no pressure. Now, if you get it wrong, you'll be like, oh, it's the worst. So what's this one? It's such a beautiful example. You got this lobulated thing, and you don't have to describe it. You can just tell me what you think it is. A couple lobules here. Hibernoma. It's a beauty, isn't it? Oh, swoon. I never get this in molluscum, man. Although I see molluscum a lot more often than I see hibernoma. So hibernoma is a tumor composed of brown fat, right? And brown fat, as Van, who I see is on this video, Van Hung sees all the time, right? Because it's in babies. Occasionally you see it retained in adults too. Brown fat is made of 3 different cell types, and hibernomas are made of 3 cell types, okay? And this case is perfect because it showcases all 3 of them beautifully. Number 1 is regular mature white fat, adult fat, okay? Mature adipocytes in here, sometimes of varying size. Number 2 is these multivacuolated bubbly cells that look a lot like lipoblasts, right? They have lipid bubbles in them. But unlike, say, a pleomorphic lipoblast, they don't have big, ugly nuclei. They have uniform round nuclei, which I think we can see here. Yeah. There's no nucleus in this section, this plane of section for this one, but the nuclei will look similar to these. They're round, uniform nuclei, and they have central prominent nucleoli. That nucleolus is normal for hibernoma, okay? Don't get worried or think that's atypia. That's normal. And just like in a lipoblast, because these are lipid bubbles, they are clear and they're very sharply circumscribed, and they indent the nucleus because they're not compressible and they push everything else out of their way. And I've got a video on my YouTube channel about how to identify lipoblasts that kind of talks about that concept. So even though these are not lipoblasts, these do have lipid bubbles in them that indent the nucleus. So these vacuolated cells in dermatopathology, they're taught as mulberry cells because they look like mulberries are kind of like blackberries or raspberries, but bigger, and they grow on trees. I don't know. There might be a French name for them that probably sounds much more beautiful. But in any case, these multivacuolated cells are cell type 2. And then number 3 are the cells that have this granular pink, reddish pink cytoplasm, kind of variable amounts of it. And sometimes you can see kind of a mingling of the bubbly cells with the granules in the background. What are these little granules? Why do these cells look so red and grainy and beautiful? Yeah, they're packed full of mitochondria, right? And the interesting thing about brown fat, and you can try this out once we get back to having cocktail parties and see if your friends like it, is that the mitochondria in brown fat have their electron transport chain decoupled. Remember back in biology in college how you learned about the electron transport chain and then it never was useful again pretty much since? Well, actually, it's cool because it's supposed to make ATP, right? But in brown fat, supposedly, the electron transport chain is decoupled from the ATPase. So as the electrons move down the chain, instead of making ATP, they just make heat, make extra energy. And the idea is that bears have extra brown fat and it makes them warm in the winter and they hibernate and thus hibernoma. And I don't know how we know that any of this stuff is true, but that's what's said, okay? That's what the story is. And it makes a real nice story that I think is cool if you're like a science nerd like me. So anyway, the thing that is also important to know is that while this hibernoma is very rich in these red, grainy cells packed full of mitochondria, not all of them are. Some hibernomas have mostly white fat and just a little bit of the reddish cells or the multivacuolated bubbles. So all 3 of those cell types can be present in varying proportion in hibernoma. These tend to occur in young adults. They tend to be decent size. Sometimes it can be 5-10 centimeters and down in the deep musculature. Even though they are taught in dermpath, I have never yet seen one of these in the dermis or even the subcutis, honestly. And I've seen a lot of soft tissue tumors now. So maybe like Chris Fletcher or somebody has who's seen way more than I'll ever see. But I've never seen one in the skin. And if you're, have any of you seen it in the skin ever? Van, have you seen a hibernoma of the skin? Cool. Okay, and if you're watching this online, please let me know in the comments if you've seen one of these before. And I'm probably, if I look in the literature, someone's reported like a series of 3 cases or something. But in any case, so know that the composition can change. They're real rich in vasculature, And these are going to be hot on PET. The PET will pick up brown, even normal brown fat is hot because these are mitochondria are active, right? And so they're PET avid a lot of times. And then the other thing that I wanted to point out, sorry, I caught my microphone. Can you guys still hear me? Yeah. Good, okay. And the other thing that I wanted to point out was something good, I thought. Oh yeah, because they're larger, deeper, fatty tumors, they often on imaging get mistaken for liposarcoma because they look like a big, deep, fatty tumor and have areas that are not normal fat consistency. And so they can, to those who are not aware, they can be concerning for liposarcoma on imaging. So sometimes they're concerned about these, and these are totally benign. There are rare times you can see brown fat. I've heard that it can happen in well-diff liposarcs. I don't think I've ever seen one yet that has it, but people who train me told me they've seen a few. And then also, I have seen sometimes in the high-grade form of myxoid liposarc, you can have brown fat differentiation. I've seen that like once or twice. But otherwise, when you find this, I mean, these are benign, and you're done. The diagnosis is there. Hibernoma, and that's just a real beauty. I can't look away. It's so good. All right, so switching gears. Here's a piece of a tumor. Again, it's a big, deep, soft tissue mass. Anyone want to take a stab at what this might be? That's fine.
Yeah, I have alveolar sarcoma.
Okay.
Alveolar sarcoma. Metastatic RCC. I thought like some of these cells look like rhabdoid, and we have a pseudo-alveolar growth.
Yes. So it's a good differential. Yeah, anyone else can chime in if you have different ideas. I'm not sure what much else I would think of for this, but let me show you. There's one area I want you to see that is probably no one paid attention to because this stuff is much more interesting to look at here and much more classic. But look at this area here. This area is kind of different. There's no alveoli here, right? There's like kind of these rounded epithelioid or almost rhabdoid cells arranged in multiple little clusters or nodules, almost a touch Zellballen looking, really. When you see a tumor composed totally of stuff like this, you could certainly think of like a paraganglioma a little bit. At least I have on ones that look like this. But when we have this, I don't think paraganglioma would really be in the differential here. But yeah, this is alveolar soft part sarcoma. These are exceptionally rare, even among sarcomas. In many sarcomas, I see a lot of in my practice. I'll say I see myxofibrosarcoma maybe, or liposarcomas a couple times a month, I'd say. I've seen 2 alveolar soft part sarcomas in 8 years of practice, and I saw a couple in my 1-year fellowship. They're very, very rare. I think the biggest differential at this is between metastatic renal cell carcinoma, because there are some forms of renal cell carcinoma that can have a lot of overlapping features, and I'm not a genitourinary pathologist, but I definitely have seen some times where you could have overlap there. A very common thing that is talked about in the differential because of this alveolar pattern, and so this is what's meant by alveolar for anyone who's watching this that's a junior or beginning, is these spaces that are open in the center and lined by cells on the outside, just like the alveolar air sacs in the lung, right? So the idea, though, is that this is basically, these tumors actually start as kind of solid nests, and then in the middle, the cells fall apart and break down kind of, and become loose and discohesive, and then the cells are retained around the edges where you have the vascular channels in between them. And that vascular channel between these kind of nested look, that's what gives it kind of the look that mimics renal cell carcinoma, I think. But yeah, so these are not like really true alveoli, they're like pseudo-alveolar spaces. Now that same thing is what happens in alveolar rhabdomyosarcoma, that these nests fall apart, but there's one big difference. At what is the main cell type of alveolar rhabdomyosarcoma? Anyone want to answer? Like if you had to describe it in one category, from low power, what would you think of? This is kind of a read my mind sort of question. Well, Well, only some of the cells usually. So in alveolar rhabdomyosarcoma, you will get some scattered cells that can look kind of rhabdoid and eosinophilic cytoplasm like this. But you may see striations, although they're often pretty hard to find, but sometimes you will. But they're a small round blue cell tumor. Most of the cells in alveolar rhabdo are round blue cells, actually. and then they fall apart, and so they leave make an alveolar architecture, but most of the cells making up the lesion, and Van has probably seen a lot more alveolar rhabdos than I have as a pediatric pathologist, but the majority of the alveolar rhabdos that I've seen predominantly look like a round blue cell tumor, and they can have like solid pattern where they don't make the alveolar spaces. So to me, actually, even though a lot of people think of ASPS, alveolar soft part sarcoma, and alveolar rhabdo in the same differential, I feel like usually they look pretty different. Actually, they do make alveolar spaces, but the cells, if all the cells looked as pink or clear or pale looking, large plump cells with big nuclei, and there's no round blue cells, then it's probably an alveolar soft part sarcoma, not an alveolar rhabdomyosarcoma. That's the way I've always thought of it, at least. Okay, I added this in after the lecture so that you could see a comparison, or a contrast rather, between alveolar soft part sarcoma and this tumor, which is alveolar rhabdomyosarcoma. See how different they look from low power? Yes, there are alveolar spaces right here where the solid nests of tumor cells start falling apart, and there's a single layer lining the outside, and then a bunch of tumor cells floating in the middle. So it has that in common with alveolar soft part sarcoma, but that's pretty much where the similarities end. Otherwise, this tumor looks more or less like a round blue cell tumor to me most of the time. Sometimes they do have clear or eosinophilic cytoplasm, but it's usually in a subset of the tumor cells, and they can have solid areas like this. That's actually an important thing to keep in mind. So I'll give a closer look here at the alveolar spaces. But see, they look mostly round and blue with relatively minimal cytoplasm in most of the cells. Even closer look. And that's a really great classic example. And in between the nests, you have this prominent fibrous, fibrovascular septa that are dividing each of the nests from each other. So there's a fibrous tissue with a prominent vessel that subdivides each of the nests. Even in the solid areas, finding that fibrovascular septation between pockets of round blue cells is a characteristic feature. Here's some necrosis right there in the middle of the tumor. And then up at the top, if I recall, let me see if I can find the place again. Oh, here's some more of the pseudoalveolar spaces. And there are a few cells in this one, if I recall, that were kind of pink. Ah, there they are. See those guys? There are a couple cells that have prominent eosinophilic cytoplasm, and sometimes you'll find actually plump rhabdomyoblasts or strap cell type rhabdomyoblasts in alveolar rhabdomyosarcoma, but I think the best way to learn it is a small round blue cell tumor that makes alveolar spaces and then has variable amounts of eosinophilic cells scattered in the midst of it. Now, I don't see these very often. I feel like they often get seen by pediatric pathologists, at least in the areas where I've practiced, and so I only have encountered a relatively small number of cases, so I'm certainly not a world expert on rhabdomyosarcoma or anything like that. But from the ones I've seen, they're round blue cell. Here's another example that's, I think, even more dramatic for how much of a round blue cell tumor it is. I mean, look, you would look at this at first and you might think of Ewing sarcoma or something like that. But then here you see the fibrovascular septa in between, dividing the cells apart, and then a layer of cells clinging to those septa, and then falling apart, discohesion of cells in the midst of the tumor. And this case also, I'm going to show you one other feature. I know the point of this was not to show you everything about rhabdomyosarcoma. I'll have to save that for another video. But these cells right here are relatively characteristic multinucleated tumor giant cells, and they often have eosinophilic cytoplasm with kind of a ring of nuclei around the outside, and they're a relatively characteristic finding for alveolar rhabdomyosarcoma. But again, they look quite different, I think, from the cells of alveolar soft part sarcoma. So I hope that helps clarify to be able to see alveolar soft part sarcoma and alveolar rhabdomyosarcoma back to back. Okay, back to the original video. And unfortunately, this slide I uploaded, I think I must have scanned it only at 20x and not 40. So the nuclei of these cells are big, and they often have these little notches taken out of them. And I wish I could show it closer, but see how there's a kind of a little notch, a little divot. So what Mark Edgar, one of my awesome soft tissue mentors, he said that they look like an apple with a bite taken out of it. And if you go get a chance to look real close up, and I wish I would have scanned this higher res, but the scanner that I had access to previously sometimes had some trouble with high res, you will often find these little notches or divots taking out of the nuclei in alveolar soft part sarcoma. A really nice subtle pearl from Mark Edgar, who taught me many kind of awesome pearls like that. All right, I recorded this after the lecture, and I wanted to insert it into the video so that you could see a better example of the so-called apple bite cells of Edgar, in honor of my mentor Mark Edgar, who first taught me that term. And it's pretty useful clue for alveolar soft part sarcoma. You can see these indentations taken out of the nuclei, like someone took a bite out of an apple and tossed it aside. Let's go in for a closer look, see if we can get them in focus here. If you focus up and down, you can see that basically what this is, that they're notched or indented nuclei, but I like the visual analogy that someone took a bite out of an apple. And not all alveolar soft part sarcomas have them, but I feel like you often do see some degree of indentation or kind of crinkling of the nucleus. See how there's like a little dent right here? These guys have multiple dents, like someone took a bunch of bites out of them. So this is a pretty good example, but I had to go and pull through my collection, and some of the cases of alveolar soft part sarcoma in my archive study sets didn't really have this very good. So it's clearly not a well-developed feature in every case, but I think it's kind of helpful, and plus I just thought it was a really good analogy for remembering this feature. Apple bite cells in the nuclei of alveolar soft part sarcoma. The other thing that's a little unusual is what's the molecular abnormality with this tumor? Does anyone know the genes involved? It is. Yeah, it's X17, right? It's the chromosome X with the TFE3 gene. And remember that TFE3, so it will stain positive in the majority of alveolar soft part sarcomas. It's a nuclear stain, but it also can be seen in other things, okay? So there's a variety of other entities that can have TFE3 expression. So it's not a totally specific thing here. Now, I think the main thing is when I see something that looks like classic alveolar soft part sarcoma, the main thing I want to do is do keratin or maybe Pax8 or something to make sure that I've excluded the possibility of metastatic renal cell carcinoma, which is, of course, going to be much, much more common than alveolar soft part sarcoma. Oh, you mean could alveolar soft part sarcoma look a little like a granular cell tumor?
Yes.
Oh, yes, some of the cells could look a little granular, but the big difference for me is that granular cell tumors usually are not well circumscribed. They are really trickly at their edges, particularly when they're in the dermis. They look like they infiltrate. They intercalate is the word I like to use, in an interstitial pattern in between the collagen bundles. And when they get down in the muscle, they do the same thing. They just kind of splay apart all the fibers, and they make this nice syncytial sheet of cells. And I think I've got a short video about granular cell tumor on my channel. But the alveolar soft part, on the other hand, is very nicely arranged into very circumscribed nests. And so that's a big difference. Even though you're right, they could look a little granular in their cytoplasm. So this is alveolar soft part sarcoma. The other things that are kind of worth noting, we talked about it being rare. Let's see, RCC. The other thing is, look, right here, we've got a vascular channel plugged full of tumor. How often do you see lymphovascular invasion in sarcomas? Well, I'll tell you, not very often, okay? It's pretty rare. Even though we know that sarcomas must spread through the blood, the theory is that they're hematogenously spread, the majority of them at least, because they metastasize to lungs first, usually. But even so, we don't often see them actually invading the vessels in the excision specimen. I've seen it a handful of times in different sarcomas, but not common. But alveolar soft part sarcoma is one where you can regularly find vascular invasion. And also it's strange that in addition to metastasizing to lungs, it can go to weird sites like the brain. Most sarcomas do not metastasize to the brain. Alveolar soft part sarcoma does, though, sometimes. So it's kind of a strange tumor in many different ways. And I've met some people online through support groups who had alveolar soft part sarcoma, and their course was relatively delayed. Even once they had metastases, they still lived for quite a long time. But the long-term prognosis of this is very guarded. A lot of patients develop, I can't remember what the exact percentage is now, but a lot of patients develop metastases once they get these. So they can be a very problematic tumor, and one to always be on the lookout for. And do remember that sometimes they can be composed totally of solid nests without good alveolar spaces. And it seems like, if I recall, one of my mentors said that they felt like they saw that more often in younger patients, that younger patients had like kind of a more cellular tumor that had not opened up into alveolar spaces yet. I just have not seen enough to actually know if how well that comparison works. But in any case, just remember that when they're solid, you could really struggle, I think, with recognizing that they have that they're alveolar soft part sarcoma. And I think that when they're solid, they can really look Zellballen and really mimic paraganglioma. So I always try to keep ASPS in mind in a differential when I'm thinking of paraganglioma and vice versa. I was never really taught that, but I definitely saw a few cases in training that confused me. Oh, and the one other thing is that if you've watched some of my videos, you know probably that I like to harp on the fact that the vast majority of balanced translocation sarcomas have uniform monotonous nuclei, not pleomorphism. But one exception is alveolar soft part sarcoma, that it can have scattered random big pleomorphic cells, even though it's a translocation tumor. I don't know why that is, but I've seen several of the cases I saw had pleomorphic tumor cells just like this here. And that kind of random pleomorphism, again, could make you wonder about a paraganglioma or something, although the nuclear chromatin is not really good for paraganglioma here, but certainly it'd be worth thinking. So, okay, that's alveolar soft part sarcoma. Any questions? All right, then let's go on to next one, case 3. And some of you might have seen that this very slide made an appearance online probably yesterday or something, I think. All right, this is just such a good example. The best example I've ever seen of this entity. I don't think I could ever see a better one. Does anyone know what this is? Oh, everyone answered, but I think you all said spindle cell hemangioma. Yeah, it is a spindle cell hemangioma, and in the olden days, originally it was described as spindle cell hemangioendothelioma by Sharon Weiss, my soft tissue mentor, and over time, because these are often multifocal, so the idea was that maybe there was regional spread, regional kind of metastases, but then when they followed the patients up like 10 years later, no one had progressed disease, and so the idea was that these really are benign, even though they can get into vessels and they can be multifocal. And so so now we call them spindle cell hemangioma. And the first and most important thing I like to say is from low power, you're going to see it's biphasic, right? There's 2 different zones. If you have a good example like this, you get an area with big dilated cavernous blood vessel spaces, and then another area with cellular kind of compressed sheets of cells. So the cavernous spaces look pretty similar to what you'd see like in a so-called cavernous hemangioma or venous malformation, which is what those things probably actually are. And there's a whole new classification system for all the different vascular things. And I feel like the pediatric pathologists stay up to date with that a lot better than I do. You can see some spindle cells in between, but they really have nice, well-formed vascular channels that are dilated and lined by bland endothelial cells. The cellular area is going to be the cause of more confusion and angst, I think, because it's made of spindle cells, but also kind of plump epithelioid-looking endothelial cells. So even though we call it spindle cell hemangioma, it usually has a component of epithelioid-looking endothelial cells. And I think that anytime we see a vascular thing with epithelioid features, it starts getting people worked up and worried about the various hemangioendothelioma sorts of things, right? So these areas have these plump cells that have vacuoles. Many of the different vascular tumors that have epithelioid endothelial cells have the ability to produce little vacuoles in them with varying kind of little nuances there. But these solid areas will have like little compressed channels. And if you're having a really bad day, you might think that these are kind of like the slit-like spaces of Kaposi sarcoma. I feel like the look is, with practice, the look is kind of different really from Kaposi sarcoma. But I'll tell you, to me, the most helpful thing of looking at this to think that it's not Kaposi is this. I don't know if I've ever seen Kaposi sarcoma occur as a circumscribed subcutaneous nodule. I've seen it make kind of a circumscribed nodule in the dermis that was exophytic and pushes up, like the nodular form. But I feel like I don't think I've ever, and I've seen a fair number of Kaposi, so maybe there's exceptions to all rules, but the fact that it's a circumscribed subcutaneous nodule in this case is a pretty strong evidence to push against it being a Kaposi sarcoma. Although I will point out Kaposis can sometimes have cavernous channels like that. Okay, the other thing I want to point out is this, and this is so fun. Look at this. What is this stuff here? What's it look like to you?
What stuff? Oh,
Yeah, these little white things. Like, they look like fat cells almost, don't they? Yeah, to me, they look like kind of little mini tiny fat cells. And that's another Mark Edgarism that he taught me this in fellowship. So both Sharon Weiss and Mark Edgar were my two main soft tissue mentors when I was at Emory, and just really just changed the course of my career working with them. It was such a wonderful experience. And Mark, again, with his really witty little, comparisons visually, he's like, these look like little mini fat cells. And sure enough, most spindle cell hemangiomas I've seen have these. And these actually are not fat cells. They're actually these little vacuoles in the endothelial cells that are just really ballooned out for some reason. I don't know why. So in the solid areas, if you find these little clusters that look like little tiny baby fat cells trapped in here between the spindled and epithelioid endothelial cells, jackpot. That's spindle cell hemangioma. That's like such a classic appearance. And again, see how they get epithelioid out there? So they're not all spindled. And if you really wanted to put an HHV8 on, I would never fault you. That's such a great stain. If you have any worry for Kaposi sarcoma, it's very sensitive and specific. And obviously you want to make the proper diagnosis of Kaposi. So if you have access to that stain and you have any doubt, is one stain, and it's an easy way to almost certainly exclude Kaposi sarcoma. The other thing that we'll talk about here is this. Here's a pre-existing thick-walled muscular vessel, and you can see the tumor is growing out of, basically, through the wall of this vessel and bulging out from it. You can see the same thing over here. So this is another cut of that same vessel, and that's the other reason I really love this case, is because it's got, I remember when I first got this, it was early in my practice, and I was just like, oh my gosh, this is the coolest thing ever. So, I mean, I'm easily entertained. And these are also totally benign, which is great. And finding them coming out of the wall of a vessel, while that might seem disturbing, that's actually a really good diagnostic feature to support spindle cell hemangioma here. So that's a great example of that. And does anyone know the molecular finding here? Although I've never actually had to use it in real life. There is a molecular abnormality that was described in these in the past 10 years or so. Yes, IDH1 mutations, which is interesting because what kinds of patients, there's a certain syndrome where patients get multiple spindle cell hemangiomas in addition to something else. Does anyone know? Maffucci syndrome, which is basically multifocal chondromas of the bone and chondromas in the bone, and they tend to be like multifocal in the hands and very distorting. And those patients get have the addition of getting spindle cell hemangiomas. And it's interesting because the Maffucci's is due to a germline mutation in IDH genes. I think both IDH1 and IDH2 can be involved in Maffucci. And then also we found that spindle cell hemangiomas, even sporadic ones, usually have mutations in the IDH genes. So it's kind of interesting that we have this disparate group of tumors that have IDH gene mutations. And, some gliomas also have IDH, right? And then there are other, IDH is a isocitrate dehydrogenase, a Krebs cycle enzyme. And we're now finding a variety of other tumors where Krebs cycle enzyme gene mutations are driving the growth of the tumor. So it's really kind of fascinating and interesting. Another thing that learning from pre-medical education, about the Krebs cycle that now is becoming interesting and important for a totally different reason. So I think it's really fascinating. All right. Okay, so the question is what about Kaposiform hemangioendothelioma? So those also are composed of spindled endothelial cells, but instead of Kaposiform hemangioendothelioma, instead of making a solitary mass like we'd see in spindle cell hemangioma, they usually have multiple small swirled nodules of spindled endothelial cells with little blood-filled spaces in them. And then they kind of infiltrate out through the skin and the soft tissue, and they have dilated lymphatic channels. So that's, to me, the biggest difference there is kind of the low power, that those tumors, the ones I've seen, were usually, maybe there's a couple rare exceptions, but usually kind of an infiltrating tumor rather than this tumor, which is usually relatively circumscribed. So that's the one difference. And I will have a video coming out soon that briefly touches on Kaposiform hemangioendothelioma. They're also quite rare, and of course, usually occur in pediatric patients. Okay. So case 4. Let's turn it up. Let me turn it around here. Another beauty. What is that? Yeah, plexiform neurofibroma, did you say? That is a good thought because it does have a multinodularity, and that brings up a great question, which we'll discuss. That's not what this is, but I appreciate that that point because there is certainly a multinodularity. What any other ideas? Myofibroma. So these become pretty easy once you've seen a few of them. But at first glance, they can be quite confusing for a few reasons, okay? So I'll tell you the features here. Another biphasic tumor. You have these nodules, okay? These nodules are called myoid nodules because they're supposed to be kind of myofibroblastic or muscle-like, even though these tumors usually express actin but not much desmin, or no desmin usually in my experience. But this one, you can kind of see how they look a little muscle-ish, myoid, because they're kind of pink. But a lot of times, the predominant color of these nodules is blue. So I think they can be so blue that they look myxoid, or they even look chondroid. Pseudochondroid is what I like to call it. I think that I've made that up because people always talk about them being myoid, but I'm like, most of the time when I see them, they don't really look myoid. And I've had people send me biopsies of myofibroma thinking it was a myxoid tumor, or thinking that it was a cartilaginous type of tumor. So I think that this kind of myxoidy or chondromyxoid looking nodularity is often the case, that the pink gives way to blue. So don't let that confuse you. And then in between these nodules is cellular substance filling the space between the nodules. Let's go out here and look, because this is where it looks really nice. These cellular areas are more primitive looking cells, kind of round to spindle cells, very bland usually. They don't usually have atypia or pleomorphism, although they sometimes can have mitoses, and even you can get some necrosis in these occasionally, particularly larger ones in young kids. And these are basically like kind of pericytic cells, kind of similar to the cells you'd see like in a glomus or a myopericytoma. Now in the more recent WHO, myopericytoma and myofibroma are kind of like grouped together into a similar related category, which is kind of interesting. So this stuff is kind of related to what you'd see in myopericytomas. And then you have these cellular spindled areas with dilated kind of branching vessels, often kind of with a staghorn or hemangiopericytic appearance. And in fact, in the past, there was a tumor called infantile hemangiopericytoma, and now we recognize that that tumor is actually probably just a very exuberant form of myofibroma, and that the use of that term has been discouraged. So in any case, that's what you're going to see, these multiple myoid nodules, often with a kind of bluish pseudochondroid appearance, and then in between the nodules, this cellular zone of spindle to round cells with branching dilated vessels. Very nice, and these tumors are totally benign. They rarely recur, even when they're partially removed. I've seen one that did kind of persist and grow back a little bit, and sometimes they even regress on their own. So these are most well known, I think, for being in children, where they can be multifocal. Babies can be born with many of them. Sometimes they even involve the internal organs, in which case they can actually be serious and fatal. Even though it's a benign tumor, if a patient's born with like 100 of them in their lungs, there's going to be a problem, right? So we recognize that they're in kids and multifocal, but also they can be solitary and they can be in adults, even old adults. I've seen these in elderly patients even, usually as solitary lesions, although occasionally I've seen adults with like 2 of them or something, which is always kind of interesting. So a real good thing to recognize, benign and beautiful. And let's go back to the point that you made about plexiform neurofibroma. So I see exactly why you thought of that, and I think that's really important that you bring up, because a lot of times when we look at a plexiform neurofibroma, the first thing that strikes us is its multinodularity. All of those twisty infiltrating nerve trunks, when you cut through them, they look like multiple nodules packed together. So the thing is that a lot of other tumors are multinodular, but not truly plexiform, not that 3-dimensional bag of worms look. But under the microscope, multinodular and plexiform can really look very, very similar and identical. And it can lead us to call things that have a multinodular appearance and get them confused with plexiform neurofibroma. I would say that the one thing that would help in here, this stuff could look a little bit like what you see in neurofibroma, kind of irregular, haphazard spindle cells. The cellular zones out here are a little bit unusual, although diffuse type neurofibroma can get sheets of round cells sometimes. I got a neurofibroma video on YouTube that's kind of long, and in there I show a case, I think, of a diffuse neurofibroma, and that can be very confusing for people because of the round cell kind of look that they have sometimes. But in this case, though, I think that the look is a bit different, but the multinodularity can really confuse you. And it's these nodules that I've found give people the most trouble when I've had myofibromas sent to me in the past. Okay, any questions about myofibroma? Ganhung Wen is saying that actually what they see is not so much of the hypercellularity over at the edges, but these kind of less cellular areas that are bulging and growing into, pushing into vessel lumens, and that in the pediatric population, he sees this as kind of a more typical sort of feature. That's really cool. Thank you for sharing that with me. I love learning new things about morphology, Because, molecular is cool, but there's always, to me, like something about seeing these little fine visual details that really makes pathology so fascinating and sometimes very diagnostically helpful when we find those. Okay. So what's number 5? Let me go over to the other profile. I think it's better. Yeah, this is just another example of myofibroma. See, sometimes I trick you and put the same thing twice. This one looks a little different than the last one, right? It does have some of that myoid nodule, but certainly not that. It doesn't look quite as like strikingly biphasic. The nodules are a little bit more poorly formed and kind of, you can really see that they have kind of a muscle sort of appearance. I think of these as more kind of pericyte or myofibroblasts rather than true smooth muscle. And then sometimes the nodules can be kind of smaller and kind of poorly formed. I think that those can be a little trickier to recognize. But again, you get the kind of branching, clefting, hemangioparasitic type staghorn vessel growth and some vascular channels in here that are kind of tangled up in the mix of it. So that's pretty cool. So just 2 different kind of flavors, and then a bit more of that looks like the nodules kind of in the last one. Okay. And I guess this is more of that kind of pushing growth, kind of looks like it's growing into the lumen of vascular channels that Van was mentioning. Well, I mean, they're put in the So the question is, is there really a difference between myofibroma and myopericytoma, and how do we really distinguish? So for one, I don't know if we really need to distinguish because they both are benign, although there have been rare exceptions of malignant forms of myopericytoma. I've seen 1 or 2, and but they're quite rare. But for the benign ones, I mean, they're both benign. They both can involve vessels, and you shouldn't get worried about that. To me, I think the difference that I think of is that I think of myopericytoma as being composed pretty much entirely of this cellular round to spindle pericytes, and it often has this whirling, swirling growth around vascular channels within the lesion, and it doesn't tend to have these kind of hypocellular myoid nodule areas. I feel like when I see those myoid nodules, that's going to point me to myofibroma, not myopericytoma. Okay, so what's going on here? Any takers? I'm not telling you. You tell me what it is, then I'll tell you how old they are. But as I said, but the fact that you're asking that tells me that right away you clearly know that this is a child, and you're right. How you can figure out even from low power, you can get the impression this is a fibrous hamartoma of infancy, usually obviously in infants and young children. And the thing that can be kind of scary about them from low power is they look like a pink spindle cell tumor with entrapment of fat. So if you're having a bad day, you could see this area and think dermatofibrosarcoma protuberans. You could see this is a honeycomb pattern of fat entrapment. It looks relatively similar sometimes. But the components of fibrous hamartoma, there are 3. I will tell you in a minute. But the other thing I want to point out is that when you look from low power, in DFSP, normally there's one kind of main tumor mass, not always, but usually, and then it infiltrates out towards the periphery and you get that fat trapping. But here, where's the center of the tumor? Like this thing? Like it's all just kind of a patchwork, all like hodgepodge together, like a quilt almost or something, right? That there's a lot of different areas that are busy, but it doesn't seem like there's any one main tumor mass infiltrating fat. It's just all kind of mixed and intermingled together. The one area that could be confusing is this up here, which if I recall, I want to say that this was a scar from a biopsy, but I can't remember for sure. And I think that as this got larger, they just took it out because it was making a mass, not because they were worried about it. But I can't remember the exact scenario. So there's 3 components to fibrous hamartoma of infancy. And what are those 3 components? Exactly. Yeah, so the 3 things are fat, fibroblastic spindle cells running in parallel, like nice, well-formed fascicles. See how like nicely packed those are and how they really run kind of almost like the fascicles you'd see, say, in a desmoid fibromatosis, just a lot smaller, nowhere near as long or as broad, but very much parallel fascicles of fibroblasts with background collagen. And how do we know that these are fibroblasts and collagen? Because look at that waviness right there. When collagen gets really wavy, it looks almost like ramen noodles in a package. And I've got a little video about that. One of my former fellows, Ed Fulton, said it's the ramen noodle sign. And so I've now dubbed it the ramen noodle sign of Ed Fulton in his honor, because I just think it's such a beautiful analogy that when you get this really ripply, wavy looking collagen, that's very characteristic of dense regular connective tissue like tendon, fascia, or ligament, and also of fibroblastic or myofibroblastic proliferations. So you can see that with spindle cells and collagen wavy like that, you're almost certainly dealing with fibroblasts or myofibroblasts, and really unlikely to be dealing with nerve if it's that wavy. Exceptions exist, but usually. So yeah, you get the fascicles of the fibroblasts, the mature adipocytes, and then these little round nodules, which really to me are the key to making the diagnosis. And we call these immature mesenchyme because we say they look immature. I don't honestly really know what immature means. I'll be honest and say that. I mean, to me, I guess it means like they look like cells that don't look like anything else. Or I guess like some areas of in fetal development, you get like some cells that are just in these sheets like this. So I guess if I knew more embryology, probably I would recognize why that looks immature. But for me, they're kind of these little balls of round to spindled cells. They're arranged in tight aggregates, and they often have kind of a grayish, bluish sort of looking background in between them. And so you can see them there. You can see them up here. See, again, they're here. So that's a really nice example of fibrous hamartoma of infancy. You don't want to confuse it with dermatofibrous sarcoma protuberans, which can also occur in kids. Here's more mesenchyme here. So if you're having a difficult case, looking around for these is really the key to making the diagnosis. Otherwise, the other tumor that can kind of look like this is lipofibromatosis in childhood. They can have like these fascicles that really intersect and trap fat and can have a lot of overlapping features, I think, in some cases with fibrous hamartoma of infancy. And so in challenging cases with those, getting someone involved who knows about pediatric pathology can be helpful because they're much more likely to have seen cases of those. Oh, and the one other point I'd make is that I don't know, I've seen a fair number of DFSP now, but I don't know if I've ever seen them with really good fascicles. The only time they make really well-formed fascicles is when they're fibrosarcomatous, and then they're going to be not fascicles spaced out with a pink background. They're going to be like blue hypercellular herringbone fascicles that look like synovial sarcoma, kind of. So not like these fascicles that are hypocellular and pink with collagen dividing the cells nicely. So if I see nice fascicle formation like this, that's a good evidence it's probably not DFSP if I'm having any trouble. And look again, look at that ramen noodle sign. You see what I'm saying? Look at how wavy that is. So nice. Wavy, if it's really wavy, usually means fibroblast, not nerve. Contrary to popular opinion. All right. Questions? Yeah, good question. So how do you distinguish it from fibromatosis? Well, good. If you have fascicles that look like this, you could seriously consider fibromatosis. But finding the mesenchyme, those mesenchymal islands, I've never seen that in desmoid fibromatosis. The other thing I think that's helpful is that in desmoid tumors and fibromatosis, you can get entrapment of fat and of skeletal muscle. Particularly, I think I see entrapment of skeletal muscle even more than fat, but at the periphery of the tumor. But you'll get like little islands of stranded atrophic muscle in it, or you'll get little blobs of fat here and there. But you don't see desmoid tumor do this. Desmoid tumor, I've never seen it do that, like make like a honeycomb kind of pattern. DFSP can do this, but desmoid fibromatosis, I don't think I've ever seen it like trickle in between individual adipocytes. It's more like broad fascicles going out and trapping little groups of fat in it. And also, there's going to be a main tumor mass that's going to be huge, really broad, long, sweeping fascicles. That's the main tumor mass, and the fat infiltration or muscle infiltration will be just seen at the periphery. So that's the other thing. And then the final thing is that I don't think the only times I've ever seen desmoid fibromatosis in the skin and subcutaneous is if it's growing from down below, like off of the abdominal rectus muscle sheath, and then pushing up. I've seen it do that, but it was like an 8-centimeter mass coming from deep, pushing up into skin. But it's usually desmoid tumors are deep soft tissue tumors from the fascia or below, whereas fibrous hamartomas, I think all of the ones I've ever seen have been subcutaneous and sometimes with involvement of the dermis, but they usually are centered in the subcutaneous, and they're often on like the chest, near the upper chest axilla shoulder region in kids that are, infants or 1 or 2 or 3 years old, something like that. So any other comments? Van, as a pediatric pathologist, do you have any comments you want to share with us?
I think the most challenging
I'm having to repeat this so it goes onto my microphone, but Van Hung, a really excellent pediatric pathologist, I'm glad to hear that he said that even he struggles with telling fibrous hamartoma of infancy apart from lipofibromatosis, except for the main thing being the presence of these mesenchymal islands in fibrous hamartoma, but not in lipofibromatosis. So I'm glad to know that I'm not alone, because I've often found it very challenging otherwise to sort them out. So Okay, great. So next case then, case number 7. Any takers on this one? The idea that was said was desmoplastic fibroblastoma, which is actually what this is, or maybe low-grade fibromyxoid sarcoma, because it's kind of fibrous and it's kind of myxoid. And I think that fibroblastic and myofibroblastic entities in soft tissue pathology can actually be quite challenging to learn, because for a lot of them, they're composed of fibroblastic cells, which are kind of nondescript usually, and then have a variable amount of collagen, sometimes with some myxoid change in the background. And it's really a matter of like the pattern of how those are arranged with each other, and then also some clues like the site and the age and stuff like that. And there's a lot of them don't have good special stains to use. There are some that do, and a lot of them don't have good molecular. So it really comes down to a lot of nuanced pattern recognition coupled with some cheating by using, I say cheating, but by using the clinical history and the site to know. So this particular lesion was on the palm. It was an acral site. So I know it's not the genital stromal tumor, angiomyxoma, and those usually have more kind of rounded cells. But I find genital stromal tumors actually very challenging category, which is part of why you've not seen me make a YouTube video about those, because stuff that's difficult, I try to avoid making videos about because it's hard, and I struggle with it too. So the thing I think that helps the most about these is usually they're composed of one or multiple pretty sharply circumscribed nodules, although I've occasionally seen ones that were more loosely arranged. They often are down in the subcutis or near the tendon. I feel like the majority of the ones that I've seen have been at the distal extremities, like the wrist, the hand, the foot. I think most of the ones I've seen have been there. And they tend to be collagenous in the background, but often have variable amounts of myxoid change, sometimes quite a lot of myxoid change. So I actually chose this case because I feel like most of the ones I've seen had some or even a lot of myxoid change in them. But I think the best thing, and again, I should have just let Mark Edgar teach you guys this lecture, because yet another thing that he taught me was these cells here, the way he explained them, they're fibroblasts, right? But they look a lot bigger, and they're kind of stellate or triangle shaped. You know, stellate means star shaped, but when we say that, you know, I never see cells that look like a 5-point star. They look like kind of squished triangles. So I'm a very concrete thinker. I don't have good abstract thought. That's what my wife tells me, and she's a psychiatrist, so I have to believe her. So in any case, though, I feel like that to me, I want things to look exactly like they're told. But Mark Edgar said what these look like is that these look like splattered cells. Like if you took the fibroblast and you dropped it off the top of a high building and it went splat on the concrete, that's what the cells look like in desmoplastic fibroblastoma. The other name for this entity is collagenous fibroma. And I love that because that's exactly what these cells look like. And even to this day, my good colleague, Sarah Shalin from Arkansas, who I worked with for the first 8 years of my practice, she'll be like, oh, hey, look at the splat cells. So we always just call it's the splat cells because that works so well. There are other entities that can have these fibroblasts or myofibroblasts with purple, bluish amphiphilic cytoplasm and a kind of stellate look. But when you see the hypocellular lesion, circumscribed lobules, these splattered looking cells scattered about on the surface of the tumor, collagenous fibroma or desmoplastic fibroblastoma. And I will point out over here, and although it may cause you anxiety and pain, I should probably tell you there's another tumor that sounds very similar in name to this. It's called a sclerotic fibroma, also known as a storiform collagenoma. And why everything has to have at least 2 names in soft tissue pathology, I don't know. But the problem is that storiform collagenoma and collagenous fibroma, they sound a lot alike. And for the first few years of my practice, even after doing a fellowship, I won't lie, when I went to sign out one of those entities, I made sure I looked it up to get the name right, okay? So those lesions are in the skin and they have a plywood appearance. Very beautiful to look at, but they look quite different than this, but they have a name that sounds similar. So this is the entity sclerotic fibroma, aka plywood fibroma, aka storiform collagenoma. And these were described in Cowden syndrome patients who get multiple lesions like this, but they can also occur sporadically. And I think the plywood fibroma name is the most visually appealing because it really does have this cracking wood-grained pattern. You can see it's intradermal, it's very sclerotic, and it has these cracks in between the collagen that give it this swirling, whirling kind of plywood or wood-grained pattern. And these are usually circumscribed lesions that are present in the dermis. And you can also see this similar pattern in dermatofibromas. I've seen it in inflammatory settings. So it can be seen in other things. It's not totally specific, but it does look very different than desmoplastic fibroblastoma, aka collagenous fibroma, which is the entity I was just showing you. So I wanted to show you as a comparison, the names are maddeningly similar, but these are very different lesions in their presentation and their appearance. And here's a closer look at that sclerotic kind of plywood pattern, and there also. So that is, this is sclerotic fibroma, or storiform collagenoma, plywood fibroma. This is totally distinct and different from desmoplastic fibroblastoma, aka collagenous fibroma. You're gonna have to practice those names a few times to get it. Like I said, it took me a couple years into practice before I could do it from memory. So these big splatter looking cells I don't think I've seen in low-grade fibromyxoid sarcoma before, but if you had any doubt about low-grade fibromyxoid sarcoma, I would never fault someone for doing a MUC4 immunostain, which should be positive in the vast majority of low-grade fibromyxoid sarcomas, but negative in this entity and others to my knowledge. But you know, low-grade fibromyxoid does have zones of sclerotic collagen and alternating with zones of more loose kind of myxoid stuff. It usually will have a bit more cellularity than this entity here. But yeah, I would never fault you for doing a MUC4 really on any low-grade fibrous looking tumor that has some myxoid background. I would always rather people overuse that stain than miss a low-grade fibromyxoid sarcoma, because they're very treacherous and easy to miss if you don't have much experience, and even if you do. And I have a whole long video about low-grade fibromyxoid sarcoma, also known as Evans tumor, on my YouTube channel. You can check it out. And I also have a short video that explains real quickly how to tell low-grade fibromyxoid sarcoma apart from myxofibrosarcoma, low-grade, because those sound maddeningly similar, but they actually look quite different. So, do you guys love soft tissue pathology yet? I hope so, because it's so fun once you get really good at it. But the problem is it's all rare, and it takes a long time to get comfortable with it because you just don't see this stuff very much. So that's why I'm trying to put more and more slides from my collection out on the internet as whole slide images and make videos so more people can see and learn about this. Okay, any questions? So that's a good question. I feel like the cytology looks different. The plump splatter looking cells look different, but the collagen background very much has the shredded carrot kind of look of plexiform neurofibroma. So yeah, that's a good point. I didn't think about that, but these could get confused. And the easy way to solve that would just be doing an S100 or a SOX10, which would label plexiform neurofibroma and be negative in this entity. Great question. And these are also benign. Very rarely will they recur, even if they're taken out with positive margins, although most of them that I've seen kind of shell out like this because they're like sharply circumscribed nodules. So question about extravasated red blood cells. What does it mean? That's a great question. I actually have no idea. I don't know if I've really paid attention to that. And I have to be quite honest. People talk about this as being an important feature for nodular fasciitis, which there certainly are some areas of this lesion that could look like it, because again, fibroblastic and myofibroblastic things often share a lot of overlapping morphology with one another. Even though it is a common finding in nodular fasciitis, I have never gotten really convinced of the utility or usefulness of that clue. Although I have colleagues who staunchly disagree with me on that and find it to be a very helpful clue. So it may just be that I've not picked up on that nuance yet. I find other things like little myxoid pseudocysts and some stuff like that to help me with nodular fasciitis. But yeah, I don't know why there's extravasated RBCs here. You're definitely right. It's pretty prominent, and I guess I just never paid attention to it. So thank you for bringing that up. Maybe it's a feature that's common in these, and I just haven't noticed that yet. So I'll keep a lookout in the future. Yeah, so the point made is that in fibromatosis, you can have extravasated red cells. And in fact, in fibromatosis, you can have areas that look very much like nodular fasciitis, although it will be that plus the presence of broad sweeping fascicles. But I find particularly intra-abdominal desmoid fibromatoses, I feel like they especially seem to have this very feathery tissue culture look with myxoid backgrounds, and that's a common finding in particularly in the intra-abdominal forms of desmoid fibromatosis. So yeah, definitely. I've had occasional cases where I struggled on a small biopsy to tell something as being nodular fasciitis or desmoid tumor. Oftentimes, if you're lucky, you'll get clinical info, and if it's a 10-centimeter mass coming off the rectus abdominis, guess what? It's not nodular fasciitis then. So that can be pretty helpful, but other times it can be challenging, particularly like in the breast. I feel like telling apart small fibromatosis versus nodular fasciitis in the breast, I've really struggled with that on a few cases. Okay. Next one. Let me turn it right side up. Okay. So what's this beauty? So you guys really notice the fact that there's a lot of inflammatory cells scattered about in this thing. It is a myxoid lesion, but lots of inflammatory cells, right? And that's, yeah, so you could think of a low-grade myxofibrosarcoma or myxofibrosarcoma grade 1. You could also think about low-grade fibromyxoid, I suppose, because it's got pink and blue areas and kind of variable cellularity. The one thing I would say is that looking around this lesion, most of the cells, oh, that area is out of focus, I forgot. There's one part of this slide that didn't scan in focus. But let me find the area that did. I feel like most of the cytology of these cells is very bland. You got these nice little nuclei, they're pretty uniform. They've got some pink cytoplasm. A lot of them are spindled, although some of them look a little bit kind of reniform, like little bean-shaped nuclei. You can kind of vaguely appreciate it here, maybe, or here. But there are some that kind of have a bean-shaped look with a little blob of pink cytoplasm. And so that can be pretty helpful, I think. But I would, for myxofibrosarcoma, even grade 1, to me, there must be at least some pleomorphism. You got to have at least a little bit of scattered, truly atypical cells to be able to recognize or to meet the diagnostic criteria for that tumor. So what I will tell you is that this is a hypocellular myxoid lesion. It's, here's the skin up top, right? It's kind of a circumscribed nodule or multinodular mass in the subcutis. You saw it has scattered inflammatory cells. Particularly one cell I want to point out is it's got not just lymphocytes, but it has some scattered neutrophils in it. I think we saw them best in that top area. Scattered neutrophils in a myxoid tumor is a really useful clue, and I'll tell you in a minute what it means. Yeah, there we go. There's like some scattered neutrophils in the background, and that is an unusual thing. You know, neutrophils, I feel like neutrophils are only present like in derm path too. In certain things, like they usually mean something when they're somewhere. They don't just kind of hang about. Like lymphocytes, you can find them anywhere. They're like a dime a dozen. But I feel like neutrophils, they're usually there for like some sort of reason. I don't know why that is, but it seems like it. And then down here, there's sclerotic collagen probably related to this ruptured structure here. And what is this? What's that? This is an epidermal inclusion cyst, and here's is actually like a hair shaft right here. There's loose keratin. There's stratified squamous epithelium with a granular layer up top. So this is basically, and really what this is probably actually a dilated cystic hair follicle, but it did get entrapped in the middle of this tumor. So this was and you know, the things we call epidermal inclusion cysts in the skin, they're actually really probably follicular cysts. Most of the cysts in the skin arise from various parts of the hair follicle, and then there are some rare ones that are of sweat gland or other derivation. But yeah, this is, oh, and I did a review on cysts, and I got the whole thing online. If you guys want to watch it, I did it for my intermediate level resident session here for my dermatology residents, and we went through a bunch of cysts, including some esoteric rare ones. So if you're looking for all you ever wanted about cysts, go check it out. Okay, so putting all this together, and then, oh look, there's vessels too. These kind of delicate vessels branching. So this is actually a cutaneous myxoma. And you might say, this looks totally different from like an intramuscular myxoma. And yes, that's true. The superficial, cutaneous myxomas have another name, superficial angiomyxoma. And I kind of like that name because it gets across the idea that in the skin, myxomas usually have a prominent branching kind of plexiform vasculature. It can look even kind of a little bit like the chicken wire vasculature of myxoid liposarcoma, although much less delicate. Myxoid liposarcoma has a very, very delicate vasculature. And these vessels actually have like a bit of a vessel wall to them. And you can see they're branching about. So we've got a hypocellular myxoid lesion. It's got bland spindled cells. There's a good one. Some of them, I hope that transmits across, have a bean-shaped nucleus with a little fat pot belly of pink cytoplasm. Yet another thing that Mark Edgar taught. See, he really liked to teach these funny little visual clues. And for some reason, the way his brain was wired is like, it totally is exactly every little pearl of what he said. Oh, this looks kind of like this. I was like, yes, that's exactly what it looks like. So I don't know. It's like we're kindred spirits, I think. And then cutaneous myxomas, in addition to having the branching vessels, and this kind of cell right here, this little pot-bellied bean-shaped cell, is very similar to the cytology you'd see in a deep myxoma, like in the muscle, an intramuscular myxoma. But in intramuscular myxomas are usually less vascular. And the other thing that cutaneous myxomas have that's unique is they sometimes have scattered neutrophils in them. I do not know why. I don't know if anyone does. And it's not always there. I can't remember if it's 30 or 40%. But when you find it, it's a really helpful clue. So if I see a myxoid hypocellular tumor in the skin, the first thing I do is, are there any neutrophils? That can be a helpful clue. The other thing is I think about half of these will entrap adnexal structures. So you can get cystic hair follicles with keratin lining. I've also seen ones with entrapped sweat ducts, sweat glands, and they often, because they get trapped, they fill up with sweat and they get cystically dilated and distorted. So I've seen those. So entrapment of adnexal skin structures is a useful clue for myxoma. They also tend to be multilobulated like this. And I think those are all nice features. And this one does have a little bit more sclerotic collagen than usual. And I think that that's partly due to the rupture of the cyst. So superficial angiomyxoma, aka cutaneous myxoma. And there's a syndrome that sometimes has these. And what is that? Yeah, Carney complex can have cutaneous myxomas and a variety of other things that you can go look up. It's a long list. But the majority of times I've seen cutaneous myxomas, they've just, to my knowledge, been solitary and sporadic. The times that particularly, which is kind of interesting, but particularly the people that have carnies, they get cardiac myxomas. And then also when they get cutaneous myxomas, they have a tendency to get them on the eyelid, near the ear, or on the nipple. So in those locations, if I see a myxoma there, it might not hurt to just put that on the clinician's radar to like, hey, sometimes the Carney syndrome has myxomas in these locations, and it may not hurt to do some more workup just to make sure they don't have any, other signs or symptoms to suggest Carney's. And they do have a decent tendency to recur. They are benign, but I think something like half of them can grow back. So local recurrence is not uncommon. But I feel like if the majority of the lesions excise, it's fair to just watchful wait. And if it grows back, then you can take it out then because they are benign. So nice example of cutaneous myxoma. Any other questions? Yeah, okay, great point. That the one entity that really does sometimes come up in the differential, especially on a small superficial biopsy, is how do you tell myxoma from focal cutaneous mucinosis or focal dermal mucinosis? Usually those are smaller and centered in the dermis, but I've definitely had times, particularly on a partial biopsy, where I couldn't be sure. The good news is they're both benign, but again, that lesion is just a deposit of mucin or myxoid material in the dermis and really doesn't have any risk of recurrence or anything to my knowledge. But these sometimes do recur and have sometimes a syndromic association. So the things that help me is if it's multilobular, if it has got prominent vasculature, if there's scattered neutrophils. Although sometimes if it's in the dermis, if it's ulcerated on top, you're going to have neutrophils because of an ulcer. So I've definitely had times where I wasn't sure, and I've actually described it as a hypocellular myxoid process, and that it could be dermal mucinosis or a myxoma. And the main thing on a superficial biopsy in the skin of a myxoid lesion, the main thing I want to make sure is that I'm not getting the top of a large, deep lesion that could really be something else more serious. Particularly, I worry about that in the setting of old people on the extremities, where myxofibrosarcoma is most commonly found. And the surface of a myxofibrosarcoma in the dermis, they can be very hypocellular and have bland areas. And on a partial biopsy, they could be pretty tricky. And I had one not long ago, actually, that I diagnosed as a punch biopsy, and they were concerned it was a big basal cell or a DFSP. It, it didn't look like classic myxofibrosarcoma clinically, and I just got a punch biopsy, which thankfully had very obvious atypia and was definitive. But it's certainly, if you hypocellular myxoid things that are partial biopsy of a large deep lesion, more workup or maybe complete excision might be needed depending on the scenario. So yeah, it's a good point. All right, I'm editing this and adding in after the fact. This is my little triad of questions for intramuscular myxoma. Looking, is it hypocellular, is it hypovascular, and does it have bland nuclei? If yes, then it could be a myxoma, but if not, consider other options. And like I said previously, cutaneous myxomas, aka superficial angiomyxoma, actually have prominent vessels. And here's just a quick look at an intramuscular myxoma. You can see it splaying apart the skeletal muscle bundles there, the skeletal muscle fibers, and it's very hypocellular. And then here's that cell I was talking about. You can see them both in intramuscular myxoma and also in superficial angiomyxoma or cutaneous myxoma. You have this bean-shaped nucleus with a little blob of pink cytoplasm. And that's the belly, the little fat pot belly that Mark Edgar taught me about. And I think it's a really cute name for these little pot belly bean-shaped cells that you tend to see both in cutaneous and in intramuscular myxomas. So that's the cell I was pointing out. Case number 9, where I don't know if we'll get through all of them. I'm going to try to go faster. Okay. Any takers on this one? Yeah, I mean, I just don't think there's anything else that this could be except synovial sarcoma, right? It was, I can't remember if it was like a arm mass in a middle-aged adult and a core biopsy. And here we have a cellular spindled proliferation, and the spindle cells are very uniform. They are mitotically active and kind of hyperchromatic, but they are not pleomorphic because it's a translocation sarcoma, right? And I would say that by far more common, I see monophasic synovial sarcomas that are completely composed of these uniform spindle cells, often arranged in kind of fascicular herringbone pattern. And only occasionally do I encounter the biphasic ones, which is it's kind of like a rare opportunity to see them. And this was like the best example that I had seen for a long time because it's got this perfect glandular-like structure the tumor cells make and have an epithelioid morphology and arrange into these glands. The glands often look like they have kind of mucin in them, but actually a lot of times it's kind of degenerated, kind of beginning of necrotic tumor cells. At least that's how Dr. Weiss explained to me that a lot of times it's kind of debris from dying tumor cells that mimics secretion in a lumen. And so the presence of those together, I mean, it almost reminds you a little bit of like the endometrial glands and stroma. I mean, not really, but it kind of has that same kind of pattern of glands with columnar sort of cells and this very cellular spindled stroma. So in any case, though, as an extremity lesion, I think if I recall, I actually just signed this one out on H&E with no molecular or immunostains because I just said there's to me nothing else that this could feasibly be. And then on excision, of course, that's what it was. So this is a really classic, as good as it gets example of biphasic synovial sarcoma. And I'll often mention if it's monophasic or biphasic, but in reality, to my knowledge, there's no difference in prognosis or treatment between them. It's just a morphologically interesting thing. So I think the main thing to learn when you see the biphasic, that's good, but recognize the uniform monotony of the cellular spindled area. I mean, really, when I first saw synovial sarcomas, when I first started residency, it reminded me a lot, and maybe I'm just not good, but it reminded me a lot of like ovarian stroma. I feel like the cellular blue, very uniform cells of ovarian stroma could kind of have a lot of similar appearance to what you see a synovial sarcoma look like. And I got a whole long video about synovial sarcoma, so you can learn all about it if you want to. Okay, we'll move on so that we can try to get through them all. All right, so this one, 10 and 11, I can't remember if I told you, but they're the same tumor. Same case, actually, just two different areas. I think the morphology is better on this piece, and the next piece is just cool because of the bone and its situation to the bone. So here, I'll show you case 1 just to refresh your memory, or piece 1. And then here's piece 2, where you can see bone here. Does anyone know what bone this is? I didn't tell you any history. What is it? The clivus would be a good idea, but try the other end instead. This is all the way at the other end of the spine. Yeah, it's actually at the very tip of the sacrum. It's the coccyx. Yep. I mean, isn't that an amazing section? I don't think I've ever seen a section, you know, this is anterior posterior section, got sagittal right through the coccyx. And you can even see here is the very end of the coccyx, and here is the fibrous the fibrocartilage of the disc. Isn't that amazing? So fascinating. And you can see that the tumor is emanating out from, I mean, it honestly looks like it's out here growing into the bone, but because we know that this probably arises from right around here, you can see the tumor in the bone itself, and then making a large mass out here in the soft tissue. So now that we've looked at that one, so that is just truly an amazing section, one of the most fascinating sections I've got in my collection, perhaps, just because of the anatomic orientation. But let's go back to this piece, because I think the features are much more classic here. So what is this tumor? Yeah, that's a chordoma, which is exactly why you guys went straight for clivus, because the clivus and the sacrococcygeal area is the classic site for chordomas, right? They arise at either the distal or proximal end of the spine, right? And the idea is that the notochord embryologically, that as it helps form the spine and spinal cord areas, and as that all forms together, and the embryology of that is way more than I can remember. But the idea is that maybe some cells get left at the end, at either end, and that those are the precursors that give rise to chordomas. And that's a pretty cool idea, and it seems to probably have some legitimacy. But we do now know that chordomas can arise in other locations. I co-authored a paper with Dr. Weiss and some others about chordomas in outside of the axial skeleton and in soft tissue, and we even saw some in the extremity. I've seen a case in the ankle, in the soft tissue of the ankle before. And so that was kind of an interesting study. It's very, very rare, but we do occasionally see them at other sites. So it's important to keep that in mind. And also, if you see things that look like a chordoma in another site, always remember what other tumor can look a lot like chordoma. Any takers? I'll give you a hint. It used to be in the old times called parachordoma, because it looked like a chordoma but was actually in the periphery of the body, not at the axial spine or the axial skeleton spine area. So the parachordomas, I think most people now accept that they're actually a form of myoepithelioma, a myoepithelioma that has chordoid features, that has kind of cells that look like chordoma. So here's the things that helped me, and I learned this in residency from one of my mentors, Dr. Connolly. I think he said that, you know, from low power, before you go looking for phycoliferous cells, which I know is what you want to find because they're bubbly and really interesting looking, but before you do that, chordomas are often multinodular like this, and they have fibrous septations dividing the different lobules. The individual lobules themselves usually have a prominent myxoid background, and then as you go closer, the cells in there are variably epithelioid to kind of vacuolated and clear, and it can run a range. I've seen ones that were very epithelioid, other ones that were very vacuolated and almost like kind of adipocyte looking, and then of course the multivacuolated bubbly phycoliferous cells, which we'll look at in a second. But those cells, clear to epithelioid, are arranged in kind of chains and cords. I think we can kind of doubly use the word cord here. They can sometimes have sheet-like areas and nests, but they often have a cord-like pattern. And I think this is a good example of the kind of cords, the rows. They're kind of lining up and in irregular kind of elongated rows and are connecting up to their neighbors. And see, these look much more pink epithelioid cells, and then other cells look much more vacuolated. And then here you can see the multivacuolated cell, the phycoliferous cell, which I think stems from a Greek word for bubbly or something, if I recall. And so this is a good example of chordoma. You can have a variable amount of atypia. Sometimes they're very bland. I've seen some that are atypical. Sometimes they can even be like anaplastic or sarcomatoid in appearance and really have like, spindled cellular areas that are sarcoma-like. I've seen that before too. And unfortunately, these are problematic tumors because sometimes they metastasize, but the bigger problem is because of the area. They're either usually at the base of the skull or in the pelvis, and they can be kind of relentless and recur again and again. It can be very difficult to manage and get them out. They cause, compression effect on the other structures. I've seen people have hemipelvectomies for them. This patient here had a sacrectomy and significant problems that come with that, with those surgeries. And I've met some patients that had chordoma through working with patient support groups, and certainly a problematic tumor to have, and one that I think that the patient support groups actually have really pushed for more research to be done, and they've worked on funding the research, which I think is really fascinating and awesome to see patients advocate for their own health that way. So yeah, so if the phycoliferous cells are often there, but I don't feel like you have to have them. And then what's the classic immunophenotype for chordoma? They co-express what and what? Yeah, brachyury is the buzzword, right? T brachyury. I think the T's there. I don't know what the T means, but brachyury is the... Yes, brachyury is a nuclear stain. That is a very good, as far as I know, very sensitive and specific stain. Maybe there's other stuff that stains with it, but the last time I checked, it was pretty much only chordoma that I can recall. So if you think you might have a chordoma in soft tissue and you can't tell apart from a myoepithelioma, brachyury should solve that problem for you right away. Yes, the important thing I want you to remember, though, is that co-expression of keratin and S100 is not very common in human tumors, but one thing that consistently does it in the majority of cases, I've seen exceptions to this, but it usually is co-expression of keratin and S100 in chordomas, okay? So that's good. And the other thing is myoepithelial cells, both normal and neoplastic, co-express keratin and S100. And in fact, when you're looking at myoepithelial tumors of bone or soft tissue, which are rare but do occur, the normal myoepithelial markers that you would use, like in breast pathology, are not very sensitive. A lot of the myoepithelial tumors are negative for them, but keratin and S100 co-expression is one of the best reproducible things. That the vast majority of myoepithelial tumors will have keratin, or sometimes EMA instead, co-expressed with S100. So I think that that's really important to know those two things that can do that. That's good. And I think there may be a couple others. Occasionally, some types of carcinoma can express S100. I think I've heard of some breast carcinomas expressing S100. I don't know if I've seen one, but I've heard that it can happen. So, okay. Good. Chordoma. Any other questions? Oh, the idea that these look like the chain of a bicycle. That's kind of cool. I like that. Yeah, because it kind of loops around, right? So I wanted to give a shout out while I was explaining to the McGill residents about the chains and cords of chordoma. I learned from Dr. Aisha Baig, the resident at McGill, that their mentor in soft tissue, Dr. Sungmi Jung, likens the kind of curving cord shape of the chordoma cells to a bicycle chain. And I love that analogy. It's so cool. You can see these bulging kind of expansions of the little cord and chain, and it does wrap around. So thanks very much for that awesome visual tip, Dr. Jung. And Dr. Baig, thank you for letting me know about this, and also for compiling these beautiful pictures for me to add in when I was editing this video. And here's another area from the same tumor, and you can see kind of a linear bicycle chain look. Really cool, and I'm really thankful to learn that, and I'm happy that you took the time to tell me this and to make these photos for me. All right, I like that. Thank you. Yeah, I love. That's why I always talk about my mentors. Is I just feel like they've given me so much, and I feel like it's kind of stealing somehow to reuse all the things they've taught me and somehow put them out as my own. And also, I just feel like that adds. I loved when my mentors told me the things that their mentors taught them, and when they told me the story. So I feel like those stories are the part of pathology that sometimes gets lost in the sands of time. And maybe it doesn't necessarily matter for everyday diagnosis, but I feel like it adds kind of a richness to the legacy of our field. And like Mark Edgar said, he's like, a lot of this doesn't really matter. Although I kind of disagree. There are definitely times some of the subtle clues he's taught me have helped me in practice for diagnostic stuff, and the same for Dr. Weiss. But Mark said, yeah, this adds kind of a granularity, a texture to learning pathology, and it certainly makes it really fun, I think. So that's really cool, and I love learning those visual analogies. One day, maybe when I retire, I'll make a book of all the different visual patterns that people have come up with. Or maybe we can just do it on Twitter and that'll save me some time. Okay. Oh, in there, so we saw the coccyx, all right? So now we're at case 12. Also, a myxoid tumor with cords and chains of cells. You see why I put them right together? Because it's another thing that makes cords and chains. There's a handful of cord and chain soft tissue tumors. I guess I should make like a full list one day and put it on Twitter or something. But yeah, very good. Extraskeletal myxoid chondrosarcoma is exactly what this is. It does make cords and chains, but obviously the cytology is very different from chordoma. These are relatively like round blue cell tumor, right? It's a kind of uniform, monotonous round blue cells. They're grouped in these cords and chains or little clusters, and they're set in a myxoid backgrounds. And even though it is called a chondrosarcoma, it really in pretty much every way is totally different from regular chondrosarcoma, okay? So I want to point that out, that this is a unique entity, not a subtype of conventional chondrosarcoma of the bone, okay? There are chondrosarcomas of the bone that have prominent myxoid change, but that is different than myxoid chondrosarcoma. So for I always make sure that I never say myxoid chondrosarcoma unless I'm talking about this tumor. I would say it's a chondrosarcoma grade 2 with prominent myxoid change in the femur or something. That's fine, but that's an obvious bone chondrosarcoma. The other difference that I would point out right away is that chondrosarcomas of bone almost always occur in the bone or maybe sometimes on the surface of the bone. It's extremely rare for them to occur as a soft tissue only mass with no connection to the bone. I have seen like 1 or 2 times, with the exception of maybe in the joint space. Occasionally you get chondrosarcomas rising in the joint. But in any case, most of the time, true chondrosarcomas are chondrosarcomas in the bone. And then this tumor is almost always in the soft tissue with very rare exception, okay? These tumors, even though they're called chondrosarcomas, they don't really look very cartilaginous most of the time. This one gets a little bit, more chondroid here. That stuff looks quite a bit like cartilage, actually. But I would say that it's very rare to see like true, well-formed cartilage in this tumor. Okay, so if you're expecting that, you're not going to see it very often. This one's really good. That looks very much cartilage, not like normal cartilage, but it looks very much like chondroid cartilaginous stuff. But I feel like the much more classic finding that we see in these is the cords and chains of uniform round cells in a myxoid backgrounds. And then what's another tumor though that could look a lot like this? I think the other closest mimic to this. Any ideas? This is another like read my mind question, so probably not fair. But I feel like myoepitheliomas and myoepithelial carcinomas, myoepithelial tumors can definitely have areas. They're a bit different, but they definitely can have areas with little round cells like this making little cords and chains. So again, those are usually S100 and keratin positive. These can be S100 positive. I believe keratin is occasionally positive, but a lot of times they'll be negative for keratin. So that can be pretty helpful because myoepitheliomas are usually keratin positive. And then, of course, what's the molecular finding here? Good. Yeah, this is a perfectly uniform round blue cells. Probably going to have a translocation, right? And indeed it does. It's the EWSR1 gene rearranged with the NR4A3 gene exactly. So this is one that's an EWS rearrangement. And I will point out, though, much to the frustration of all, is that myoepithelial tumors can have Ewing's gene rearrangements. So this is one of those times where knowing your fish and what the fish partner is and knowing what other tumors can have that particular rearrangement can be helpful. So if you truly want to diagnose this tumor with certainty, it's ideal to either get RT-PCR or dual fish to prove that there's both the EWS and an NR4A3. Unfortunately, not a lot of labs don't offer both of those, I feel like. So it can be challenging in those cases, but if you're having trouble telling it apart from myoepithelioma. But this one is a real nice classic morphology, I think, for a extraskeletal myxoid chondrosarcoma. Now here we go. What's this? Yeah, if it were in the bone, it would be called an enchondroma. But I don't see any bone here, right? It looks like a circumscribed nodule that popped out of the soft tissue somewhere, right? And I'll tell you right now, it was probably in the fingers, toes, hands, feet. So a soft tissue nodule in those sites composed of kind of cellular, funny-looking cartilage. But then what do we call that? It's just a slightly different name. We call it a chondroma. So enchondroma if it's in bone, chondroma of soft parts or of soft tissue if it's in soft tissue. Okay. Some people also call them extraskeletal chondromas, although I kind of don't like using that word because there's other things that are extraskeletal that are bad things, right? So sometimes if words are technically correct but might sound kind of scary, I tend to avoid them and go away from them. So I don't know. Maybe I'm wrong to do that. But yeah, this is a tumor that is a true cartilage neoplasm. And what's interesting is that both in the soft tissue and in the bones on the hands and feet, cartilage tumors can look pretty bizarre and weird. They can be cellular, they can have some atypia, but usually, if in doubt, a cartilage tumor on the hands and feet is benign, unless proven otherwise. I have seen chondrosarcomas of the hands and feet, but only rarely. And the only way that I really, to definitively make that diagnosis, I want them to radiologically tell me this is a tumor that is blowing out of the carpal or metacarpal bone or tarsal bone and destroying the bone and invading soft tissue. Then, okay, now let's talk about being chondrosarcoma in the hands and feet. But otherwise, it's exceptionally rare sight to have chondrosarcomas, which usually occur in the long bones, not in the bones of the hands and feet. And again, like I told you, soft tissue, true chondrosarcomas of soft tissue only, not with no bone involvement, are exceptionally rare. Like I said, I've seen like 1 or 2. Very, very rare. So this is just an example of chondroma of soft part or soft tissue chondroma. Sometimes we say soft parts in tumor names. Kind of, I feel it's a little bit old-timey to mean soft tissue. And you can get some little clustering of chondrocytes or have single ones. But the chondrocytes can be kind of more cellular and sometimes more enlarged. And there are occasional cases of this where the chondromas of soft tissue can get osseous metaplasia and can have bone formation or really prominent calcifications in them. And it can be hard to tell that they're actually a cartilage tumor predominantly. That can happen sometimes. And also I have seen rare cases where they had like kind of scattered pleomorphic cells. And that's been described that you could have kind of symplastic degenerative atypia in these. It makes me a little nervous unless I've seen that the whole thing is out. But of the cases I've seen, to my knowledge, there was no bad behavior from them. And it is a described phenomenon. So again, if in doubt, don't call something chondrosarcoma in the hands and feet unless you have definitive evidence of it or you get an expert consult. That's my advice, because your chances of being wrong and having a big problematic situation is very high. And the one other thing I would say to think about when you see something that looks like a chondroma, what if you looked like this and you saw like some islands and nests of epithelioid cells, or maybe some tubules or actual gland formation in a background like this? What would that be? Anyone? Have you ever seen a lesion that looked like this and also had glands and tubules and ducts in it? Like maybe in the parotid? So mixed tumors can do that, both mixed tumors in the salivary glands, but also mixed tumors in soft tissue or chondroid syringomas. I mean, in the skin, we call them chondroid syringoma or mixed tumor. They can occasionally occur deeper down in soft tissue too. They are on a spectrum with myoepithelioma, and they can be very, very chondroid in the background, but then they'll have usually some epithelial elements in addition to the chondroid component. So that's another thing. If you see cartilage looking stuff and then you see glands, that's probably what you're dealing with. Oh, and no, so I am going to dodge that question. So the question is, does size matter for enchondromas in long bones versus low-grade chondrosarcoma? That is such a complicated and vexing question because in the long bones, enchondroma and grade 1 chondrosarcoma can look very, very similar, essentially identical. And the best feature to differentiate them is infiltrative growth between bone trabeculae. And the problem is that, usually we get curettage fragments, and so we can't see if there's infiltrative growth. And the WHO, the new WHO, has a change in terminology for low-grade cartilage lesions depending on where it's located, and size does play some role. But I still feel this is an area that is difficult and controversial. And I do have a video on my channel about enchondroma versus grade 1 chondrosarcoma by Andrew Rosenberg, who's an excellent bone pathologist, and he talks about some of his thoughts on that difference, which was a bit different than I was trained. So I learned a lot by sitting with him and having him teach that video. So you might check that out, because I feel like they're smarter minds than me will have to explain it, because I've been struggling with this ever since I was a fellow, and I still do not have a reliable, happy way to deal with this that makes everyone glad. So I still usually say it's a low-grade cartilage lesion, and then I give some hedging in the comment about, based on the radiology and this, I think it's a benign, or I'm worried it could be grade 1 chondrosarcoma. In the soft tissue or in the hands and feet bones, totally different story. But in the long bones, very challenging and frustrating problem. And every time I see a slide with a bunch of cartilage on it, I'm like, oh man, because I know it's going to be that same issue. So, okay. Okay, what about this one? Yeah, slam dunk, right? This is classic myxoid liposarcoma. And I just made a really long video recently about everything that you could want to know pretty much about the basics of liposarcomas. But, and you can refer to that if you want to have real in-depth discussion. A few things that help. They are hypocellular with a myxoid background. The one thing that I think is really helpful in telling it apart from a lot of other myxoid tumors is note that the cells are spread apart and do not touch each other. They they have good social distancing. Ooh, I just thought of that now. I haven't thought of that since COVID started, and that's a great thing. They have a very large personal space bubble, okay, and they're good social distancers. They stay away from their neighbors, and usually very few of them overlap. They do not form cords and chains. So unlike some of the other myxoid stuff we talked about, which have cords and chains and connected cells, you don't see connected cells usually in regular conventional myxoid liposarcoma. You see these little cells. They are also very bland. Again, a translocation sarcoma, right? So these cells have a translocation. FUS DDIT3 used to be called FUS CHOP, was the most common one. Occasionally a subset of them, like 5% or so, will have EWS-R1, Ewing's gene, rearranged with DDIT3. And so if you haven't learned yet that a lot of times if there's a rearrangement of EWS-R1 with some other gene, eventually someone's going to find cases that have FUS rearranged with that same gene, and vice versa, because FUS and EWS-R1 are similar genes, the kind of same gene family, which again, this is way over my head. I'm not a molecular pathologist. But the point is they often swap out for one another. So that's a good take home to remember. So the cells are very bland, though. You do not see pleomorphism in this tumor, with the rare exception that has been described in children of pleomorphic myxoid liposarcoma, which even though it's in the books, A, I've never seen one, and B, the concept does not sit well with me because my understanding is they behave different than regular myxoid liposarc. They're more aggressive. A lot of them do not have DDIT3 gene rearrangement, so I kind of think they're a different tumor than this. But I don't know. I don't write the book, so maybe I don't have the right to say that. But in any case, the general rule that you should take home is if you see pleomorphism, it's not myxoid liposarcoma, with the rarest of exceptions, maybe. Okay. So the thing is that by any rule, this tumor looks benign, right? The only way to recognize what this is the pattern. Cytologically, by mitotic activity, all the stuff we use to teach first-year residents how to tell what cancer is. This doesn't look like cancer, right? It looks like a benign something. And I've seen people mistake this on a needle and call it myxoma or something else. So that happens sometimes. So the cells are bland, kind of oval, round to spindle, spaced out in myxoid backgrounds. Lipoblasts do not have to be found, although usually you will see them. We're looking at them right here. They look different than the big pleomorphic lipoblasts you'd see and think of for like a pleomorphic liposarc. In myxoid liposarcoma, you tend to get either little univaculated signet ring looking cells, or some of these guys are kind of bivaculated or multivaculated, but with a tiny little bland nucleus. They see, these are multi-bubbly cells, but they just are so little, right? So the idea here is that this tumor is kind of recapitulating what fetal fat looks like during fat development in the fetus. And if you see fetal fat, which I'm sure our pediatric pathology colleague, Van Hung, can speak to, that there are times in early fetal life where the fat can have some similarity to this, that fat in embryology, my basic understanding is, starts out as a spindle-like precursor to adipocytes, and then it builds up a little lipid and makes a vacuole, and then can make more vacuoles sometimes, and then eventually grows into full mature fat cell. See, there's multivaculated adipocyte lipoblast here. So sometimes you'll see them, but I've seen cases where they were very few or absent, or where they were just like little signet ring cells. So don't go hunting for don't be worried if you don't find lipoblasts here, okay? And then finally, the vessels, which you probably all want to talk about. Let me go see if there's a better area that shows them really good. Maybe here. The vessels of myxoid liposarcoma are the smallest, most delicate vessel you could possibly make. They are like one endothelial cell thick, and that's it. They don't have a muscle wall around them. They are a single layer of endothelial cells. If you find ones with red cells in them, sometimes the red cells look like Rollo formation. There's like only room for one single file endothelial cells to go through the vessel. That's the way I like to think of them. So if you're seeing vessels that are branchy, but have like a muscle layer around them, a nice layer of pericytes, obviously around the outside of the endothelium, that's not the vessel pattern that you look for in myxoid liposarcoma. You want these super delicate vessels that look like that if you touch them, they just break open, right? Look at that. Look at those red cells in there. So tiny, right? So that pattern that people call chicken wire, which You might have heard, I don't really like that terminology because chicken wire, if you've ever seen it on a farm, is repeating perfect hexagons of metal wire. There is no repeating perfect hexagon here. And again, this is my very concrete brain that's not good at abstract thought. I want chicken wire to be perfect hexagons. So to me, I like delicate branching vessels or maybe chicken feet vessels, chicken scratch vessels. I don't know. I've heard different terms, but in any case, these are the vessels of myxoid liposarc. However you like to memorize them, this is what they look like, okay? And then here's an example of these kind of signet ring lipoblasts. And then let's see. Oh, the other thing I wanted to point out is this. See these pools of myxoid stuff? This happens in some cases of myxoid liposarcoma and has been likened to the kind of pattern of like what a lung with really bad pulmonary edema looks like an autopsy lung that's filled with fluid, and you have these big dilated spaces with the spine fluid in them. So this pulmonary edema-like pattern is a useful clue that comes up in some cases of myxoid liposarcoma. It's relatively uncommon these days to get a nice big piece of myxoid liposarcoma like this because now a lot of cases of sarcomas, big soft tissue masses, are diagnosed by needle biopsy. And then after they get a needle, these are very sensitive to radiation and also sometimes to chemotherapy. And once they're treated, they just shrink down and become very sclerotic, and they look almost like a well-dipped liposarc at that point. Oh, I will point out one thing. When I was talking about the vessels, it doesn't mean you cannot have bigger vessels in the tumor. I mean, there has to be a feeder vessel. So you will see big vessels in the middle of myxoid liposarc, but those vessels are not the vessels that we're talking about. These vessels, you need to have those really to make a good diagnosis of myxoid liposarc. So if you got branchy vessels that are thicker than that, that's not the kind of vessels. There are other tumors that have those branching vessels. Oh yes, sometimes you can get a variable size of mature adipocytes in a myxoid liposarcoma. So if you see mature fat there, that's totally fine. It happens sometimes. And then finally, what I point out is over here, something different is happening. So what's this? Cells are not really doing their social distancing well. They're starting to get close and overlap. Yeah, very good. So this is what historically has been called round cell liposarcoma, which is basically like the high-grade form of myxoid liposarc. There has been a recent trend against using this term. I still put it in parentheses when I make this diagnosis because people are familiar with it. But I think the WHO now says that when we see more than 5% of the tumor have a hypercellular, kind of larger round cells that are packed close together, that we say it's a high-grade myxoid liposarcoma. So now that's what I'll say is high-grade, open parentheses, quote, round cell, close parentheses, myxoid liposarcoma. And so if you see necrosis or more than 5% of the tumor with a round cell morphology, then that's when you make that diagnosis. On a needle, that's very problematic because often on a needle, you will have no idea if you're going to get that much. Although I've seen cases where very skilled musculoskeletally trained radiologists were able to find the area that looked more cellular and less fat or myxoid density and then put the needle in that area, which is really helpful. And that's why working with really good radiologists is a lifesaver when you're a soft tissue pathologist. And then these particular cells are very vacuolated, and I've definitely seen that in some high-grade round cell myxoid liposarcs where there was very vacuolated, prominent vacuoles. I've seen some that had brown fat, like I mentioned earlier. And the problem is it can be a little hard to tell, like how much is enough to call it round cell? Like, what about this? Is this round cell? No. At the periphery of the lobules in myxoid liposarcoma, the cellularity tends to get increased. This is totally normal to see at the edges of lobules. And what I learned in fellowship after asking Dr. Weiss's question many times is, if I thought, could it be round cell? The answer was probably no, it's probably not enough. So that's what I learned is, in general, back down if there's any doubt. But this area here, I mean, this is an area that the whole thing doesn't look like normal myxoid liposarc anymore. It may not be sometimes it can be like solid sheets that look almost like Ewing sarcoma or like a poorly differentiated round cell synovial sarcoma. This one is not doing that. This has still got some myxoid background, but the cells are way too cellular to me, and I think are enough to make the criteria. And I've had occasional times on a needle where I said there's a little increased cellularity. I don't know if it's enough to be round cell or not. The problem is if they pre-treat with radiation, a lot of the stuff melts away, including the round cell. So the excision specimen, there's no way to really know. It's not like there's any real major difference, though. It's not like we have some special therapy to offer. The treatment's going to be probably the same, although I've seen times where they decided to only give radiation on a regular myxoid liposarc, and then when it was a high grade, had round cell, they were debating whether they should add chemo plus So I've seen times where it was taken into account, but there's not like a solid, definitive treatment plan difference in the literature, to my knowledge. Although I don't know, I'm not an oncologist, so there may be a lot of nuance beyond what I understand. So I just think a main important morphology is recognize those cellular areas that look round blue-like. But even when they're there, usually you'll still find the delicate vessels in the background, and usually there'll still be some component of myxoid material in between the tumor cells. So keep that in your round blue cell differential, although only rarely have I seen it where a whole core was all round blue cells. I have seen that, but it's very rare. Usually there's myxoid areas present. So, any questions?
Do your surgeons ever ask you to report the actual percentage of round cells?
No one has yet, but I think the only thing that really matters is, if it's more than 5%. And the general rule is if it's on a needle, if I see stuff that's definitively round cell, then it doesn't really matter to me. At that point, the possibility of the tumor having less than 5% and the needle magically hitting the 2% area, that seems very unlikely to me. So I usually, if it's on a needle at all, I report it. On an excision, it's just so rare for me to get a full excision. Like, I can't remember where I got this set. I think I might have got this from an old study set, actually. I don't think this was a case I signed out in practice. So I don't know if I can remember actually seeing a full excision where I had obvious round cell and could even give a percentage. So in general, I like to avoid giving actual percentages on stuff unless I'm forced to, because I don't feel like I'm very good at estimating it, which is part of why I like derm path and soft tissue and not other parts of pathology where you have to calculate percent of key 67 staining and stuff. So anyway, I don't know if that's a good answer, but it's an honest one. Yeah, so the question brought up is that post-treatment, once these tumors have been radiated, they usually, the vast majority of them, just completely get wiped out, and all that's left is sclerotic collagen, a little bit of the vascular branchy stuff, and mature adipocytes with occasional little tiny lipoblasts, maybe a few pockets of myxoid change. And if there was a round cell component, you'll never know because it usually gets wiped out and blasted by the radiation. So I agree, that's the problem. The trade-off is that doing the needle ahead of time to get the diagnosis on a needle biopsy allows you to make a diagnosis and pre-treat the tumor. The trade-off, though, is that on the excision specimen, you'll really never probably know what the original morphology was like. And I feel like this is one of the trade-offs we've made in modern medicine, where there are benefits of having a needle biopsy before excision. A lot of benefits, and probably more benefits than risks, but there are some downsides, and that's one of them, is pre-treatment wipes out the original morphology. But again, it's the main difference is the prognosis. The long-term prognosis is worse, unfortunately, for patients that have high-grade round cell morphology. And even though the low-grade myxoid liposarcs, in the past, there was a thought that 90% of the patients were going to be okay and 10% would get mets. But I think with longer follow-up, we started to see that a significantly larger number, actually, even of people with low-grade conventional myxoid liposarcoma will get metastases. I think the WHO says, I think their current quote is between 30 and it's more than 30%, I think. And different studies show different things, so that even sometimes it's longer and farther out. Oh yeah, I forgot to mention the other weird thing that you should know about myxoid liposarc, like all sarcomas, it will metastasize to the lungs oftentimes, but it also metastasizes to very strange places. In addition to the lung, they can go to other soft tissue sites. Like I've heard of them going from one thigh to another thigh, which is bizarre. How does that happen? It doesn't make sense. Or going to other soft tissue sites elsewhere in the body. I've seen cases metastasize to lung and also to the pleura or the pericardium, like outside the heart. And the other place that they really like to go to a lot is bone, particularly the spine. So it's not a bad idea to consider whether maybe they should have imaging of the spine. I've had that discussion actually recently with one of the oncologists I know who does sarcoma, and I don't think there's really proven literature there, but it may not be a bad idea actually to get, just like we get a baseline chest CT for patients with sarcomas. For people with this type of sarcoma, I think it wouldn't be unreasonable to get a spine, CT, just to make sure that there's, people have lots of little degenerative changes in their spine. And then at follow-up, sometimes it's hard to know if there's a little mass somewhere. Is that a tumor that's met, or is it a pre-existing lesion? And I see that come up in sarcoma tumor boards again and again. So having that baseline imaging might not be a bad idea. That's just a recent conversation I had with an oncologist. So I don't know if that's a proven thing yet, but I actually liked that reasoning. I thought that was a very good idea. So I learned so much from doing tumor boards with my treating physician colleagues and radiologists in bone and soft tissue. That is just priceless to have colleagues that know about this stuff. The thigh is by far the most common site. The deep muscle of the thigh of a middle age or young adult. That's important. I guess I should have said that at the beginning. Also, it's very rare for kids to get liposarcomas of any sort. But when they do, the type they get almost always is myxoid liposarcoma. And that's a diagnosis that I want to have molecular confirmation on for sure, to be sure of. And the other thing is that in a kid, if you see something that you think looks like myxoid liposarcoma, the first thing you should think of is lipoblastoma, which can have a very close overlap morphologically and look very similar to this. There are some differences, but it's very similar. And I feel like if I've got any doubt, I want to do FISH to be sure, because the difference is totally benign versus malignant, and a big difference for the kid. And it's real easy to solve with molecular. So I've had times where I've done that, and that molecular has been very helpful in those cases. Okay. Oh, this is just an amazing, really, really characteristic example of a rare and fascinating entity. Did anyone get this one? Here's bone, okay? We're in the bone. What was that? Yes, good. This is clear cell chondrosarcoma, which is a really unusual entity because, again, it's one of those things that's called chondrosarcoma, but pretty much in every way looks totally different from regular chondrosarcoma. But here's pre-existing bone that's being destroyed and damaged. There's a ton of remodeling. The bone lines are really busy and overlapping. So reactive bone, it's like a fortress just being surrounded by the enemy here. And then what you have out here, the tumor itself, is got a lot of different stuff going on, right? And I think it boils down to kind of three main morphologic findings. So Dr. Rowe told me, always make three, make a triad of everything. And I've gotten bad because I'm very verbose and I talk a lot. I've gotten away from doing triads, but I need to start making more triads when I teach. So number one is you get clear cells, right? And remember, in pathology, when we say clear, we use that term very loosely. And sometimes that means truly optically clear, like an adipocyte, like vacuole of white space in the middle. But other times it means kind of pale pink or pale gray or something like that. So these cells, these are polygonals, what people say, or I like the term epithelioid, honestly, but these polygonal or epithelioid large cells with abundant pale or clear cytoplasm, they've got large nuclei, usually with prominent nucleoli in them, big funny looking cells. I mean, you could easily see a biopsy of this and you could mistake this. You could think about carcinoma or all sorts of other stuff, right? You could really struggle. That's number one, these big pale or clear cells. Number two, osteoid deposition. You get fine little strands of osteoid, and that's a pitfall too, because if you see a biopsy where you see osteoid deposition, you're going to start thinking of things like osteosarcoma. Or maybe I've seen a case of this that really on a biopsy strongly mimicked osteoid osteoma or osteoblastoma, which can have really busy, crazy patterned areas of osteoid that look kind of scary. So I've seen one where the biopsy showed mostly osteoid and the clear cells were very, very sparse, and only on a repeat biopsy was it more obvious. So those are challenging cases like that. And then number three, finally, the chondroid areas. Sometimes the chondroid areas really look kind of like regular cartilage, but oftentimes they're kind of myxoid-y looking. So they're kind of chondromyxoid looking background with variable amounts between myxoid and chondroid appearance, okay? So that's the three things. The big pale or clear cells, which is the real diagnostic key to this tumor. And then the osteoid, and then the chondroid to myxoid background. And again, varying components. I've seen ones that had relatively small numbers of the clear cells, and then other ones like this where it's just sheet-like. And this is probably the best example of this that I've ever seen in my time in soft tissue pathology. And then, oh, what about this? What about giant cells? What do we make of that? Does it mean anything? No, it doesn't mean anything. It means, yeah, it means we're in the bone, right? Anytime there's breakdown and remodeling of bone, because there's a fracture, because there's a tumor there, giant cells are seen in all sorts of different bone lesions, both reactive and neoplastic, benign and malignant. So, and you can even see right here, look what it's doing. Here's some osteoid or kind of cartilage almost turning into beginnings of osteoid. And the osteoclasts are trying to break it down and remodel it, because that's what the osteoclasts know to do. Is there bone? Remodel, right? They're going to break it down. So, and then here's some of the native bone, and we can tell because look, you can see the lamellar lines, the bone lines. So eventually I'll try to make more videos on bone pathology, but bone pathology is a lot more challenging and complicated than soft tissue pathology, I think. And again, when there's hard things that I still struggle with, I don't make videos about them because it takes a lot more work and I feel uncertainty. So I feel like in practice, I've seen a lot of bone pathology now, but I still find it usually quite a bit harder than soft tissue tumors. And a lot more importance of radiology. Radiology is helpful for soft tissue for sure, but it's essential for bone, really, for most things in bone. If you don't have radiology, if it doesn't make sense radiographically, you're going to make a big mistake. So really, really great example. I mean, this is the one to burn into your mind. And the thing is that these often arise near the epiphysis. They can be a big lytic lesion in the epiphysis, the end of the long bone. Yes, is there a question? Okay, so the question is, can I make a video about bone, like what is resorption of bone and what's woven bone versus, I'll try to put that on my list of things to make. But for now, I mean, a good example is like this. Here's lamellar bone, right? It's got lines. And then it's right here, this is woven bone. And woven bone is essentially, I think of it as always being pathological. Not always malignant, but always abnormal. That when the lamellar bone, when new bone is produced in the setting of a skeletally mature patient or in a setting outside of the growth plate or where normal ossification process is happening, it has these irregular lines of, if you can, this is one thing that is hard to do on digital slides, because I like to flip my condenser a lot, and I feel like that really helps things stand out in 3 dimensions, things that have like lines or spaces between objects on the microscope, and you can't do that with a digital slide. So for all the great things about digital pathology, that lack of that subtle 3-dimensionality can be challenging. So when you flip the condenser there, you'll see that there are little collagen strands, and they're all haphazard, kind of mishmashed together. That's the way I describe it. I don't know if it's good. But you can see woven bone in the setting of fractures and reactive things, but also in tumoral processes too. Both benign and malignant tumors can do it. So yeah, that's a good idea. I'll have to, I just kind of feel like I feel somewhat inadequate. I feel like there's so much more, like what I need to do is go fly down to Miami and get Andrew Rosenberg to sit down for a day with me and teach me all that stuff. Because that's what I told him to do. He came to Arkansas. Oh, sorry, I hit the microphone. To speak at our graduation banquet, and I said, hey, would you mind sitting with me? I'm doing some YouTube videos. And he's like, yeah, sure, let's do it. And he is such a dynamic, amazing teacher, and he's so incredibly knowledgeable with the very subtle nuances of bone. So if you want to learn, actually, if you want to learn some of that stuff, I should have mentioned that at first. I've got a whole, on my channel, I've got a bone histology video, and it's Andrew Rosenberg teaching me for like an hour about embryology and about normal histology, and he goes over some reactive stuff. It's like, I should actually go watch it again because there's so much I learned listening to him do that video, and I think I probably should just go and give it another watch. Probably I need to watch it like a couple times a year. And he's got one on cartilage histology as well. So actually check that out first, but yeah, I'll look into making a video like that because I do think that that would be beneficial. Yes, you're welcome. Sorry, every question you guys ask, I give you way more answer than you're looking for, but you probably know that already about me, so here we are. Okay, just imagine what my poor teachers had to deal with when I was a kid, or my wife. Oh, they're all very patient with me, though. Okay, this one's a pretty good example. Anyone know what this is? For one thing, at low power, cellular neoplasm with necrosis is malignant 99.9% of the time, right? That's a Dr. Rowe beginner rule. There's big zonal necrosis. Yes, this is pleomorphic liposarcoma, but wait, it's not spindled. Is that okay? Yes, it's okay. I'll tell you, because since I already said it was the answer. Yeah, you get multiloculated, multivaculated pleomorphic lipoblasts of varying size, but all of the cells you see have round nuclei and abundant cytoplasm. And even the ones without good vacuoles have kind of a frothy, foamy cytoplasm that you can tell looks kind of xanthomatous looking. Like you can tell there's lipid in there, even though it's not formed in the nice big bubbles. And then let me see, there was a good area with really good lipoblasts here, if I recall. Yeah, there we go. I mean, that's textbook, right? That perfect lipoblasts with the clear vacuoles and pushing in on the nucleus and denting the nucleus. So an important thing to remember is that pleomorphic liposarcoma, it's the one liposarcoma that you must have at least one pleomorphic lipoblasts to make the diagnosis. If you don't, then what you're left with is high-grade sarcoma, UPS basically, right? The thing that makes it recognizable as liposarcoma is the presence of pleomorphic lipoblasts. Other liposarcs can have lipoblasts, and you can watch the full liposarc video if you want. to learn more about that. But the one that must have it to meet diagnostic criteria is pleomorphic liposarc. There are two main patterns, and there's a lot of variability. I've seen a wide range of features in pleomorphic liposarcoma, but the two main groups that you can think of them in, and it's purely a morphologic, I don't think there's any real behavior difference that we've discovered, is they either look like cellular spindle cell pleomorphic neoplasms, or they can be sheets of epithelioid cells, okay? So I think it's important to know this because a lot of people are more familiar with the pleomorphic spindle one that looks like undifferentiated pleomorphic sarcoma, but this doesn't look anything like undifferentiated pleomorphic sarcoma, right? This looks like adrenocortical carcinoma or something. And I think that's one thing. It would be weird to have a 10 centimeter thigh mass that was metastatic adrenocortical carcinoma in a patient with no known primary, right? That would be strange. But I mean, I do feel like there is certainly some morphologic similarity there. And also in cases that don't have as much of the bubbly, foamy cytoplasm, they can just be like sheets of epithelioid cells and only have scattered lipoblasts. And those could be confused with a wide variety of other epithelioid tumors, either soft tissue epithelioid tumors or carcinomas even. And so I think it's an important thing to keep in mind because it's a rare entity among liposarcs. Pleomorphic liposarc is the rarest of the main subtypes of liposarc. It represents about 5% or so of liposarcomas. Again, this is a relatively uncommon morphologic variant of pleomorphic liposarc. So they're not all going to be this sheet-like, but do keep in mind you can have ones that are totally packed full of bubbly lipoblasts, and other ones that only have rare lipoblasts in a kind of a cellular sheet-like epithelioid background. Sometimes you can have both areas together, epithelioid transitioning into spindled. And also, I feel like the nuclei of pleomorphic liposarcoma are among the most ugly, nasty, huge pleomorphic nuclei of any tumor in the human body. I feel, and this one doesn't begin to come close to some I've seen. I've tweeted some before, just to show examples of these insane nuclei that are so massive. So when I see a sarcoma with super, super bizarre nuclei, like stuff that makes this look tame, that I always, even though it's not a diagnostic criterion, I've just seen so many cases of these that had really bizarre nuclei that I hunt extra hard for lipoblasts. And remember, if you call something an undifferentiated pleomorphic sarcoma and you miss the fact that there was a lipoblast there, the treatment for the patient is going to be the same. High-grade adult sarcomas in general are treated with wide local excision and radiation therapy oftentimes, and sometimes they discuss chemotherapy, even though we don't have really any good targeted chemotherapy that works for most of the adult pleomorphic sarcomas. Now, some subtypes of things like myxoid liposarc have specialized therapy. Pediatric sarcomas and round blue cell sarcomas get their own special therapy, so recognizing those is very important. But among the different pleomorphic adult sarcomas, pleomorphic leiomyosarcoma, pleomorphic rhabdomyosarcoma even, pleomorphic liposarc, undifferentiated pleomorphic sarcoma, which years and years ago was called MFH, and hopefully you all know by now that we should never ever do that anymore. It's a obsolete name. Well, all of those sarcomas, even though they have differences in prognosis, they are treated basically the same. And I hope one day that we come up with targeted therapies that work, but to my knowledge right now, we don't have good proven targeted therapies to separate those out. Even pleomorphic rhabdo, I believe that it normally occurs in adults, and my understanding is it's usually treated like other adult high-grade sarcomas rather than by pediatric rhabdo protocols, which alveolar rhabdo and embryonal rhabdo get treated totally a special way. Van Hung, with his pediatric path mastery, can teach you all about that. But anyway, this is just a reason to point that out, is sometimes we get real angsty over subtyping high-grade adult sarcomas. And it's unfortunately at this point still a lot more of an academic exercise than one that makes an actual actionable difference for individual patients. That said, pleomorphic liposarc, about 50% 5-year survival. It's pretty aggressive. It's a nasty tumor. And it metastasizes to the lungs and often does so within the first 5 years. And that's different from D. diff liposarc, which can look very ugly also, but actually it seems to be a slower growing tumor, although when it's in the retroperitoneum, much more, in the long run, a higher mortality rate. Most everyone dies. Most people die from it eventually if they live long enough. Okay. Oh, the last thing I would point out is that in general, if you see a sarcoma in the extremities with lipoblasts, that is going to be pleomorphic liposarcoma the vast majority of the time. D. diff can sometimes have lipoblasts, but the most common place for D. diff liposarc to arise is retroperitoneum, although I've seen a handful of them in the extremities. So if you really want to know, you can do MDM2, which is almost always negative in this tumor, and almost always positive in D. diff liposarcoma. Okay, that's enough. You can watch the other liposarc video if you want more stuff along those lines. Oh, yes, you must have a lipoblast to make a diagnosis of pleomorphic liposarcoma. Oh, no, so that's a little more complicated. The general rule, in the past, what we said, and that liposarcoma 101 video goes into this in depth, but it was easy in the old days, because the book said, the WHO book said, if it has lipoblast, it's pleomorphic liposarc, an ugly tumor, ugly high-grade sarcoma with lipoblast is pleomorphic liposarc. D. diff liposarc does not have lipoblast. And that was so simple then. And then in the 90s, Dr. Fletcher reported some cases, and Dr. Weiss's group reported some cases of things that were retroperitoneal, sometimes had well diff, and then high-grade sarcoma, so clearly looked like D. diff, but had lipoblast, and they had the pattern of a pleomorphic liposarcoma. And then with MDM2 testing, what we found is that those tumors all tested positive for MDM2. So what we now know is that D. diff liposarc usually does not have lipoblasts, but a subset of cases, around 10 or 20%. The books say 20%. That seems a little high, but maybe so. About 20% of cases do have lipoblast. So it's unfortunate. It used to be so easy to teach this, and now the waters have gotten muddied. For learning for residents, high-grade sarcoma with lipoblasts is pleomorphic liposarc. High-grade sarcoma with no lipoblasts arising next to a well diff or arising in the retroperitoneum, that's D. diff liposarc. But recognize that in practice, there are some exceptions to that rule where D. diff does acquire lipoblasts. And to really solve it, you can do MDM2. But in the retroperitoneum, this tumor almost never occurs in the retroperitoneum. And in fact, I would never believe this tumor, if it were in the retroperitoneum, I would say that it's either adrenocortical or it's a D. diff liposarc that has lipoblast. What we call that is homologous lipoblastic differentiation. And I realize it's a confusing term. It's like the idea is that the D. diff lost all of its fatty differentiation and then redifferentiated. I think Liz Montgomery has told me that's the way she thinks of it, is redifferentiating. It's a D. diff that's growing back towards being fatty. It's a little hard to wrap your head around, I think, at first. But anyway, I hope that helped a little bit and didn't make it more confusing. But I admit it is confusing. So you're welcome. But yeah, go check out that other video. And I think I explained it a little better in there because I had some slides and kind of made my points in a more structured fashion, hopefully. All right. Okay, guys. Oh, okay. What do we think this is? Good. I totally forgot that this was the next case, so I should have reviewed. Yeah, I love this section for two reasons. Number one, it shows the classic thing that you should see in D. diff liposarcoma. Unfortunately, in the real world, you don't always get this because sometimes D. diff liposarcs overgrow and there's no well diff component left. But what you really want to see to make the diagnosis totally without any molecular anything is well differentiated liposarcoma, or also known as atypical lipomatous tumor when it occurs in the extremities or the superficial soft tissue, and then high-grade sarcoma growing out of that. That's like the textbook definition. And how do we know well diff? Well, well diff is composed of mature adipocytes, often of variable size, small, medium, large ones. Fibrous bands oftentimes run through the tumor, and then we will find scattered, hyperchromatic, atypical spindle cells. Sometimes they're really pleomorphic and ugly. Sometimes they're a little bit more, not real pleomorphic, but really dark and hyperchromatic. The hyperchromasia is really helpful for these. So that's the classic triad is mature fat, fibrous bands, atypical cells. Notice that I didn't say anything about lipoblast. You do not have to have lipoblast to make a diagnosis of well diff liposarc. Oh, sometimes you do have them, but you don't have to have them, okay? Many cases I've seen that don't have them, but there's some that have a lot of them. So there's more of the atypical cells there, okay? So this is a textbook, definitive picture of what well diff liposarc looks like. And then over here, you can see it transition and become more cellular, more cellular, more cellular. And here, you've got high-grade, ugly, pleomorphic spindle cell sarcoma that looks just like undifferentiated pleomorphic sarcoma, right? No lipoblasts, just sheets of ugly, nasty cells, all right? So that is the classic definition of how dedifferentiated liposarcoma works. Again, in real life, there's plenty of times where we only see the high-grade stuff, either because the low-grade stuff got totally overrun or overgrown. We don't exactly understand why that happens. But we see that plenty of times, actually, where there's no obvious well diff precursor. Or sometimes someone had well diff in their retroperitoneum. It got removed, and then 3 or 4 years later, they get a recurrent tumor, and now it looks just like this. That's also meets textbook definition for dedifferentiated liposarcoma. So the other thing that's really fascinating about D. diff liposarcoma is it has this really crazy ability to produce a wide variety of morphologic patterns and of unusual heterologous components. And remember, heterologous is the fancy word we use when a tumor is producing a tissue type that is not normal for the tissue that it's arising from, right? So like in the uterus, when you have a carcinosarcoma, or the tumor that used to be called triple MT a long time ago, I think maybe you still use that term. I'm not a gynecologic pathologist, I don't know. But those will make chondrosarcoma and rhabdomyosarcoma and osteosarcoma. There's normally no skeletal muscle or bone or cartilage in the uterus, right? So that's heterologous tissue type differentiation. The same can be seen in different sarcomas, but particularly D. diff liposarcoma likes to do this. And I mean, this is better looking osteosarcoma than a regular osteosarcoma of bone. I've actually used pictures of this to teach my medical students about osteosarcoma, even though this is from a fatty tumor of the retroperitoneum, because it looks perfectly like osteosarc, okay? So I feel like this is one of the ones I see the most. I've seen ones with chondrosarcomatous elements. You can have muscle differentiation, all sorts. Sorry? Was there a question? I heard a... And while we're at it, this is osteoid, okay? Osteoid is that dense collagen that's being usually little lacy woven strands of it laid down by malignant tumor cells. And I've got a video, a bone and soft tissue board review. It's a long video. It's a couple hours, but you guys sat through this whole thing. So it's on my YouTube channel. And the case number 1 is osteosarcoma that goes over. Eventually, I'll break it apart and release it as a separate video. But if you want now a review of osteosarc, talking about osteoid and radiology, that's a place to start. But you can see that the osteoid is collagen that's laid down. Remember, it's type 1 collagen. And then it picks up the purple mineral is calcium. So it's becoming calcium hydroxyapatite. And the fact that malignant cells are making it, that's the definition of osteosarcoma. So here, this is osteosarcomatous differentiation, but it's arising from the D. diff liposarcoma. So how I would sign this out in this case, because I don't need to do MDM2 here, I've got obvious well diff. I would call this D. differentiated liposarcoma, high grade, grade 3. And then I put some little subheadings under it, and I would say that there's also a well-differentiated liposarcoma component identified, and then also that the tumor has heterologous osteosarcomatous differentiation. I don't put that as the main line because this tumor needs to get treated like a D. diff liposarc, not like an osteosarc. My understanding is that even tumors that make this heterologous differentiation, they don't get treated differently or really behave differently. But it's important, I think, to note it because, number one, if the tumor metastasizes, this component could be part of the metastasis. And I've seen that happen with not actually with D. diff liposarcs that I can recall, but I've seen this happen with some carcinomas that had extensive osteosarcomatous heterologous component. And when they metastasize, they look like metastatic osteosarc. So if you hadn't seen that original primary tumor, you would be totally confused. So I want to make sure to document it in the report, but for the practical purposes for the treating physician, it doesn't really make much difference to my understanding. So really, really good example of this here, of D. diff liposarc with heterologous osteosarc components, okay? And while we're on it, I will mention that when I have both components present on a wide local excision, I will usually report the margins as, a lot of times our margin will be positive and have some well diff there. And so I'll tell them like if the margin's positive, if it's for the high grade stuff or the low grade. I don't know if it really changes much for how they treat, but I still think it's worth pointing out. And also I will point out that in the retroperitoneum, it's very hard for the surgeons, even really good surgeons that deal with sarcomas a lot, to get negative margins on these tumors. They grow and intermingle into everything. And so even if I don't see obvious sarcoma at the margin, I just make a comment that, I should probably release this online somewhere, but I make a comment that because mature adipocytes are a component of well diff liposarc, I don't see obvious atypia at the margin, but I can't be totally sure that the margins are clear, right? Because the fat cells themselves could be part of the tumor. I've seen well diff liposarcs that looked very much like lipoma and had very few atypical cells. So it can be really challenging sometimes. So this is the textbook definition. And remember, most of them don't have lipoblasts, okay? So that's a good question. So I personally don't love the MDM2 and CDK4 immunostains. Now, I do know really good pathologists who do like them, like Liz Montgomery, for example, who I really respect and look up to. And we co-authored a soft tissue survival guide book, and she said that she likes to use that marker. And I've met people that use that kind of as a screening marker, that if it's negative, you're good to go probably. If it's positive, then you can confirm it with FISH. I think that's reasonable because I've seen times where things stained positive but were negative on FISH. Also, histiocytes can stain with MDM2. And I've seen a variety of other tumors express CDK4 and MDM2 that were unexpected, tumors that should not be amplified. For one of the best examples is I saw a case that had been misdiagnosed as a, I can't remember. Well, I think they had gotten misdiagnosed as a dedifferentiated liposarcoma. It had very epithelioid cells in the retroperitoneum, and it did have foci that were strongly MDM2 positive. It was a case I had seen for second opinion. And then it turned out after the tumor was resected, it was actually a yolk sac tumor. And the yolk sac tumor had areas that had MDM2 expression. So that kind of stuff, seeing cases like that, it really scared me. And when it's hard enough to interpret in the middle of the tumor, so I feel like interpreting fat around the margins would be nightmarish. But and also, again, it probably won't make a huge difference in what they do in the retroperitoneum. They usually are already taking out as much tumor as they can feasibly get without causing, sacrifice of things that they don't want to sacrifice, right? I mean, unfortunately, I've seen cases. Just recently, a patient contacted me, or a family member did, and showed me the gross photo, and it was, part of the intestine and the kidney, and I've seen ones where they took the pancreas or part of the pancreas because the tumor grew into all of that stuff. Really, really frustrating bad tumors because they just encase everything. In the extremity, although they're rare, they're less common in the extremity, they're easier to manage because they're, between muscles and they don't get into all the vital organs. So, all right, last one, guys, we're doing it. And this is a really rare one. So does anyone know what this rare bird is? Okay. Oh, well done. I was like, well, that was bold. You were like, yep, I got it. So I'm so proud of you because I'll let you know that the very first time I saw one of these in fellowship, I was like, well, I don't know. There's like some fat here and these bubbly cells that look, I think this one didn't get scanned high enough. Sorry, should have made sure I got them 40x, but they're bubbly lipoblast cells. They're like kind of small lipoblasts that are round and kind of make little clusters or a little bit of cords and chains and a myxoid background. And so I saw it and I said, no, Dr. Weiss, I don't know. I think it's some sort of like, some sort of liposarcoma of some sort, but I don't know what kind of. It's got lipoblasts, right? And since then, I've learned that lipoblasts do not always equal liposarcoma because these really, to my eye, look like lipoblasts, right? I mean, they're vacuolated cells in an adipocytic tumor. But this is benign. It's chondroid lipoma. And so Dr. Weiss, I think, if I recall correctly, she said, well, Jared, you missed the chance to make a very rare diagnosis. And I'll always remember my shame of missing my first chondroid lipoma. And I mean, I've only seen a handful of them. They're really rare in my experience. But this was a big one. But yeah, what you look for in chondroid lipoma, these tumors to me don't really look like real cartilage, right? I mean, there's nothing here that looks truly cartilaginous like the cartilage tumors we saw earlier. But they do get a little bit of a kind of chondromyxoid background, and some of these little lipoblast-like cells do kind of seem to sit in little like lacunar spaces a bit. It goes back to the fact that I have a hard time with abstract thought, and I want things to look exactly like what the name says. So they kind of have a vaguely chondromyxoid background. These kind of epithelioid-looking cells, a lot of which have vacuoles and kind of little lipoblasts. They don't have big, ugly pleomorphic lipoblast. And then they have mature fat. And then the clustering and the kind of cords and chains of the vacuolated cells, I think, is really the most helpful feature for the diagnosis. So chondroid lipoma, a very rare entity indeed. And I do have a couple other examples that I'll have to go pull out and get scanned and then post them all online so everyone can learn from them because it's something you don't see very often. All right, any questions about that? Well, as you can tell, I mean, when I first saw one, I was like, I think it's a liposarcoma, but I don't know what it is. So I don't know. I feel like it doesn't, that's the thing is it doesn't really, it has kind of a look and nothing else looks much like it. It's one of those things, once you know it exists, you're like, oh, that's got to be that. I guess what I could think of is, I mean, I have seen a few cases of things that we think were liposarcoma and even sharing with experts more skilled than me that we all thought they were liposarcs but didn't fit into any of the classic patterns. So there are weird times where liposarcs don't fit in the exact patterns, but this doesn't really look like any of the liposarcomas we discussed, I guess you could think about chordoma a little bit, right? Some of these cells you could think are maybe they kind of like phycilliferous cells. Anytime I see kind of cords and chains and myxoid background, I always try to think of myoepithelial tumors, even though this doesn't really look like one. but over time I've seen a very wide range of myoepithelioma and mixed tumor, and so I've come to think about those entities more and more, even in things that don't look exactly like them, just because they have such a strange range of morphologic features. So, but I mean, honestly, it really just looks like chondrolipoma. So I'm editing afterwards to add this in, and I wanted to confess to you something, that when I was going over this case with the awesome residents at McGill, I mentioned that I thought it was weird that there was all of this really prominent fibrin and hyalinization in the background. There's a lot of hemorrhage, fibrin around vessels. It's very unusual, I thought. And they pointed out that in their reading that this is supposedly a feature that's well known in chondroid lipoma. And I went back and did some reading, and sure enough, somehow I either skipped that day of fellowship or maybe overlooked that paragraph in the book. But all of the sources I read, Dr. Weiss's textbook and the WHO, mentioned that it's pretty common for these lesions, for chondroid lipomas, to have prominent vasculature and to have abundant hemorrhage, fibrin deposition, areas that are hyalinized, some areas that look even like serous atrophy of the fat, and that these are relatively common findings. But as I mentioned, I think in the discussion with the McGill residents, that I've only seen a handful of these, and I just don't remember ever seeing this in the cases I saw before. So it just goes to show that there's always something new to learn, and that sometimes, even when you've been in practice a while, you can learn things from trainees. So thank you very much to the residents for pointing that out to me and helping me to learn something new. And I wanted to make sure to add that in so that all of you could know that this is actually a feature that's well described. You can see there's a hemorrhage here, hemosiderin, hyalinized collagen, abundant fibrin. So chondroid lipomas can have these features.